Hello, everyone.
Oh.
Shall we make a start?
Yeah, we can make it, Aya.
Okay. So, good morning. Hello, everyone. I am very delighted to be the one who opens this session for you today. My name is Aya Hassan. I am Pediatrics ST2 in the West Midland region. I am also the Vice President of BSAPCH, and at the same time, I am a member of the academic office, BSAPCH, which is the hosting entity for this session for today. So hello everyone and welcome to this session. I would like just to take opportunity and briefly introduce all of you guys to BSAPCH, which is the abbreviation of British Sudanese Association of Pediatrics and Child Health, and it's a non-profit and mainly educational association that aims to support the trainees in here in the UK and also to support the trainees back home in Sudan. And another very, very important aim is to promote and improve children's health in Sudan, which is, in my opinion, a very important one as well. So, unfortunately and sadly, we are all aware of how difficult and challenging the situation back there in Sudan. But we have extremely dedicated members as part of BSAPCH in an office called Sudan Office, who are trying really to support people back there and to make sure that children, despite these difficult circumstances in Sudan, they are receiving acceptable, reasonable child health care. And also, I would like to invite all of you to become members of BSAPCH, because by becoming a member, you will gain yourself a new circle of support to get you through training and living in the UK. And also you will get opportunity to be a leader, to lead projects and to join the various offices and to help us to fulfill our goals. So I would like all of you guys to go today and have a tour on our website and also to look at the registration form. And I am so excited to see all your names as part of the new members and new team members of BSAPCH. So that's all about BSAPCH. And now let's move to our session for today, in which we will go through all aspects of the interview one by one. We have very competent speakers to take you through, and I hope by the end of this session, you'll find all your questions answered, and also I hope you find it informative and enjoyable at the same time. Later, we will present our first speaker for you. All right, thank you.
Thank you, Aya, for the introduction. Nice to have you all. Good morning and good afternoon for all our audience from various regions. It's an honor to present Dr. Bassam Jurad, and nice to have you today. Dr. Jurad has been a consultant pediatrician since 1996 with a special interest in allergy and asthma, and he previously served as an associate medical director in children and young people in Susan Trust. He's clinical director in pediatrics at Daisy Hill Hospital and hold as a role Royal College tutor and MRC PCH examiner. Nice to have you today, Dr. Gerard. Please, you can share your slides, please.
Thank you very much indeed for having me, and thank you for organizing, for inviting me. صباح خير لكل المعنى إذا كنتم بالسودان أو ببريطن. I have special fondness for Sudanese people since I heard Sayyid Khalifa singing Mambo Sudani many years ago. Maybe the new generation might not know about it at all. Can you see my slides?
Not yet.
Not yet.
Let me see. Start again. Let's go to sharing again. Can you see me at all?
Yes.
Yeah. Mm-hmm.
Okay. Well, thank you very much for inviting me. I'm just really going to talk about today about clinical thinking and just basically how do you manage clinical session, clinical cases when during the interview. And I have supervised many overseas doctors when they work with me. And I, as I said, examine many overseas in the MRC-PCH. So I just thought maybe starting by tips to the overseas graduate, mainly that apply ST1. There's a few differences between practicing back home and practicing in UK. You always be told that when you come for the interview and to about clinical session, is just to start by saying patient safety and to say that patient safety is my priority. What that mean about having low risk attitude. You need to remember you might have experience back home in pediatric for many years, but if you're applying for ST1, you need to behave like ST1, which means you really don't take risk. I'm not saying that we don't treat our patient back home well, but we, because of the resources availability, we tend to take risk. This is not really acceptable if you practice in UK, and you need to be aware of your position and to ask for help early on. And that seeking help, sometimes we think of it as a sign of weaknesses or because we're not able to manage the case. But in the UK, it's a sign of self-awareness, which means you know that you're ST1 or even ST3, and you know your limitation, and you know that you have someone more senior than you, more experienced, and you have team around you, and you need to seek their help. The advantage in pediatric, there is advantage of having pediatric experience when you come to the nitty-gritty of managing the case, but it's important not to make it a hindrance for you. We get sometimes bad habit and early on practice from practicing in certain way back home, and we carry this with us when we come to UK, and we need the time to try to cut it down from our own practice. And many people, as you know, have driving experience back home. When they come here and try to go through the exam, they find it very difficult because they learn bad habits. And same thing in pediatric experience. It is important really to cut down the bad habit and try to tame your own experience to what is the UK practice. So always use your previous pediatric experience to your advantage rather than disadvantage. The other issue is about safeguarding. The culture clearly in Sudan or outside UK is different than UK culture. And if you haven't lived in UK for a while, you really you struggle to find to understand the culture of the parent who come to you, and you might sometimes go overboard with their assessment, and you might be prejudiced as well in judging the parents because maybe we're not familiar with the culture, or something is different from our culture. The other thing is about team working. We work with nurses obviously back home, and we work with them here. But let's face it, the way the dynamic of the team is different. Back home, the doctor is superior and expect nurses to follow their instruction. Whereas in UK, nurses are important and integral part of the team, and you need to listen to them if they tell you that a child is sick, even if that doesn't agree with your assessment, which means that you go back and reassess the child. I just really thought these tips will be useful for you, because I noticed that when I supervise many doctors coming from overseas, they find it difficult to come to terms with these basically worrying aspect if they don't understand it. Now we have a mix of ST1 and ST3, so RCPSH requirements will be different. When you come apply to ST1 in this country, you have passed foundation year F1, F2, and you might or might not have any experience in pediatric whatsoever, because F2, some people will take 4-month pediatric experience before applying ST1 in pediatric, some don't. So the expectation of pediatric knowledge is not necessarily very high, but what they expect for you is to have sound knowledge in general, which at least mean that you have capability to understand the resuscitation of a patient, regardless of the age, at least the principle of it. You understand that there is guidelines in hospitals or in national guidelines. You expect you to know about the BNF, which British National Formulary, which you use for calculating your medication. So really, there is generic knowledge need to apply here, but doesn't have to be pediatric. But as I mentioned, if you are from overseas and you have a good pediatric knowledge, that's good, use it. But as I said, be aware that you're applying for ST1. The other issue about prioritizing clinical needs, which basically A, B, C, D, E, F. So you really need to know what, when you approach a sick child, you know how to, what things need to be fixed first before you move to the next bits. And this maximizing safety and minimize risk, which basically apply to seek help at appropriate stage. For ST1, I will suggest that you go straight on when you see the patient, just say, I will bring my senior. Usually your senior will be your senior pediatric trainee or registrar or specialty doctor. So you, if you get used to the saying A, B, C, D, E, F, and seek help in every, you're not going to go wrong here, and to do that early as possible. While ST1 doesn't need to have pediatric knowledge, but they need at least to be able to recognize a child to be sick child based on the scenario information given to them there, and at least to apply the first few steps of ABCD. Remember the scenario will be given in bits. That means to give you initial starter, and then as you go along, information will be given as you requested. So you need to vocalize what needs here. When you say A, you wait for them to tell you what the airway in this child, B, what the breathing this child, so information will flow, and then you could act on it. Clearly with ST3, we expect a bit more. Need some knowledge, there's no doubt about it, but they have to be pediatric-based knowledge and pediatric judgment here. Because ST3 would have had maybe a couple of years of UK pediatric practice. So the expectation a bit higher than that. So you expect as well to recognize and have management of acutely ill child, but again, expectation of management will be higher. So when while in ST1 is maybe enough to say I give oxygen or give nebulizer and seek help for a child with asthma, your expectation that you will say that this is child have life-threatening asthma attacks. I will give nebulizer. I will look for IV line to give hydrocortisone and standard treatment. But also remember, you need to seek help. And that the timing of it depends on your experience, but don't delay it. And so while you're starting the initial management, ask for help at the same time. And you need to use, obviously, the team around you. So you could say, well, I ask my ST1 doctor to put IV line. I ask the nurse to give salbutamol. I ask another nurse to call my consultant. So expectation is a bit higher then. And obviously, we expect that you know about diagnostic, how to use it, what appropriate for this child, and not just give list of tests, some of them applicable and not, some are not applicable. So you need really to be precise in these cases here. And we expectation as well that you will know a bit more about safeguarding here, and expectation as well that you know more about neonatology. Neonatology is not really something ST1 will need to know about, but ST3 need to know about neonatology. So the difference, as I said, ST3 is more in-depth in knowledge and UK experience. They need to be more familiar with the national guideline, is while ST1 can say, well, I will consult the hospital guideline or NICE guideline. ST3 need to know about them for common condition. For example, if you are dealing with asthma, you need to know about how you deal with acute attack of asthma, and to know the pathway, and you'll be aware of the algorithm of resuscitation in different cases like arrhythmia and so on. So it's not just you consult, you know about it as well. Experience in working a team, how you use a team, how you use the skills of the team. You know, nurses will know about certain things, and you will ask them to put the monitor on. You need to ask them to measure temperature, ask them maybe to talk to the parents, and depends on the team. They might give you 2-3 members of a team, or might give you 1 member of a team. They would say the hospital under pressure, so you manage with 1 member. And that's, again, one test of use of your knowledge and experience there. You need to have good knowledge about the safeguarding, about the legislation, about the general national guideline about management here. I'm aware that in different areas of UK, they might have slight differences in how they approach safeguarding cases, but there is a national guideline under the Hospice of Children Order. And as I said, you need to have experience in neonatology. Now, clinical thinking for ST1, just to expand on what we said, it's just really about common sense. Previous pediatric experience is not essential. It's useful if you have it, but not essential. So try to think again and stress this point for people who have experience overseas in pediatric. Remember ST1, which means A, B, C, D, E, and call for help. And then you could go and then you could show off your experience in pediatric, as long as you have some familiarity with the way they are treated in UK. Recognition of sick child, it's important. You don't need to know that with the diagnosis, but you need to manage that. Generic approach to assessment of sick patient. ABCD doesn't only apply for pediatric, but apply for adult and all ages. So if you know how to manage, and you need to vocalize what you're talking about here, because you don't have a patient in front of you. So when we say A, they will ask you what you're looking for here. So you're looking for patent airway. And we will say airway, if they say the child is crying, that means the airway are patent. So you don't have to ask if they're patent or not, because it's crying. You might ask, obviously, if they said stridor, that gives you an impression of certain condition. When you're talking about B, breathing, then the interviewer might ask you what you want to know about breathing, or how to assess breathing. And breathing in this case, obviously, you're talking about the respiratory rate, about use of accessory muscle, which means intercostal recession, subcostal recession, brachial tug, head bobbing, nasal flare. We're talking about oxygen saturation in this case, and if they have no monitor on, talking about the color of the child's cyanose or not cyanose here. So that always apply to breathing. And then you're talking about auscultation, whether the child have wheeze or have silent chest or normal air entry here. Then when you take about C, circulation, we are looking into the color, and so a child who is pale, have cold periphery, have the quality of the pulse. Is it normal? Is it thready? Is it weak? And talking about heart rate, and if there is a monitor about the rhythm here as well, there, and that all really give you idea. Now, just a point here, if the interviewers start to talk about the pulse and say, well, where do you feel the pulse and so on, then you need to think, especially in small baby, about asking about the femoral pulse. So the baby might be cardiac case, and they tell you the femoral pulse is completely weak or absent there, and that point you out to set one direction. So just be aware of that small things, especially the baby who came collapse and early on in their life. D is basically about neurological status. The common thing is we use AVBO, which is A for alert, V, the response to voice, P, response to pain, U is unconscious. And that's acceptable in emergency situation. If a child have clearly head injury and that presentation, you might ask about a Glasgow Coma Scale here, or as long as hemodynamically are stable otherwise, then, but you don't really waste your time with the Glasgow Coma Scale if the child need to be resuscitated. Now I put F here, and will G should be G after that, A, B, C, D, F, and because just say, don't forget glucose. You ask clearly for glucose because that's important in pediatric practice. Then you need to fix each area as you go along. Someone who have difficulty in breathing, you don't move to circulation until you apply some basic resuscitation. You put an oxygen. If you feel that they're wheezy, you give nebulizer, then you could move to circulation and go. And I said in ST1, you expect to have early call for help. Don't wait. So any scenario, just remember, it becomes second nature. Call for help and ABCD. Call for help and ABCD. Try to ask who is in the team. When they ask you call, for example, if they ask you call to casualty and you have the sick child, say who is with me? Do I have a nurse, pediatric nurse? Do I have specialist nurse? Do I have other member of AD staff, doctors? Do I have a senior AD doctor? So that's always give the interviewer idea that you're actually aware of the importance of using your team there. Apology for the typo here. Acknowledge carer and parents here. While you're doing recitation, you focus on the child. In the UK, quite a lot of time, this recitation happen with the parents are in the same room, and you need to be aware of them. And if you have enough members of staff, you might allocate one nurse or someone to speak to the parent or explain them. In my practice, usually I'm a consultant called to casualty. I actually talk to parent while I'm resuscitating, but that sometimes might not be possible, or because I have other people to do other stuff for me, so I have time to talk to the parent. But you need to find the appropriate person to talk to the parent and keep them engaged and keep explaining to them what you're doing. For example, if you want to defib a child, don't go and defib without explaining or get someone to explain to the parent what you're going to do. It doesn't look too nice for them. And I said, vocalize what you know and you don't know. So you say, well, I am going to treat this child as acute asthma. I gave him oxygen. I'm giving him salbutamol. But while I'm giving salbutamol first nebulizer, I want to go and check what the current guideline. Quite a lot of hospitals now have iPad where they have the guideline or have information available to you so you could move on, and while you're waiting for help as well. Always documentation extremely important because that's what creates a problem usually in resuscitation situation there. So when the child's stable or someone else taken over from you, just go back and document what's happened to the best of your knowledge, to the best of your memory. Try to put it in orderly fashion and timely fashion there. And then try to include that in your portfolio as CBD, or so it will be useful as well. ST3 is just really similar to ST1, but higher level in a way. So more experience, more ability to lead a team, appropriate time to call for help, and apart from starting the basic resuscitation, you will expect to know a bit about differential diagnosis, especially if you have a neonate there. And then to try to apply specific treatment. For example, if you have duct-dependent condition, you expect to say, well, after resuscitation, I expect to give him Prostin or prostaglandin E1 there just to keep the duct open while I'm waiting my consultant, because your consultant might be coming from home there. And able to handle safeguarding concern and to speak to the parent and keep parents on board, and documentation and portfolio the same way. So this is just really going back again, just this is general approach. So A, B, C, D, F, G even there, manage as you assess, go for help, use your team. The line there here is just, I expect that between ST3, ST1 and ST3, because by then the interviewer will say, well, your senior doctor came now. And then you're going to hand over to them. And it is important to be able to hand over the child condition and what you did for them. Whereas as ST3 below the line here, there, why stabilizing? Think differential diagnosis. You need to do that there. Think specific treatment. Think about whether the child needs transfer. Think whether you need to call the anesthetist. And whether they call any other specialty. So when you say a call for help, you might need to be specific. So I need to call my senior doctor or my consultant, and I need to call a consultant. Or if you have foreign body, I need to call the ANT consultant, and so on, or the airway team there. And always think parents as well. Safeguarding. Just really need to be aware of the cultural difference. Back home, it's completely different here, and that's the first time you visit UK, you'll be shocked with the difference there. Remember, it's not personal. It's not really you against the parent, and the parent might not be involved at all in it. So you need to be aware of that, and need to be careful not to prejudice. You might see someone coming to you with a tattoo covering all the skin. They might smell from alcohol, and they brought child who have bruising, and you jump to conclusion and assume the worst here. So you need to be careful about that, not only for the interview, but also for your practice. Choose your word carefully. You can't shy, especially if you are ST3, from the issue of safeguarding. By the same token, you need to be careful about how you tell the parent or how to choose your word. Always have someone with you when you interview the parent or we talk to the parent. Have a nurse or some sort, and document in details what you told them, word for word. So most of the complaint happen afterward because of misunderstanding or because documentation is poor. So if you want to say that if you have a child who is not very sick to be admitted, but you're concerned about safeguarding, then you have to say to the parent, well, I have looked into this, your child. I found there's these bruises here. I can't find any clinical cause for it. And we have to rule out possibility of someone did that for him. So, or for her. So then you have to be, but the parent obviously might be annoyed, but you say that you need to explain that you have legal obligation to look into all the causes, including possibility of someone harming the child, and that you are following the national and the trust guideline here, and you have no option but to follow it there. And you might, some parents might not accept it, but if you're choosing your word carefully, that they're not coming back to haunt you, then you're not accusing the parent because you don't know. Your role is to highlight the issue, is not, you're not a detective to find out who did it, unless there's a quite, but to document everything here. And you, as I said, you need to know something about the national guidelines, some about the regional guideline in terms of safeguarding here. You need to know, for example, in these cases, you need to inform the social worker in the hospital. You need to call, obviously, your senior court. It is important always to have a nurse with you and say, what do you think? And I think that having two opinion doctor and nurses are quite powerful, rather than you yourself just making the point. Whether we like it or not, some people look at foreign doctors that they don't understand the system, and they use that against them. So you need to be aware of that. So have someone else with you, and document clearly, in details, and as I said, in certain area, word for word, what you told them, what did they tell you, and so on. So just really have a couple of cases. I know I looked into the previous meeting, and this seemed to be a repetition of certain cases. So I thought I was just going to invent one case. So it's not. So this happened quite a lot of time. And just if you happy to ask question, or you want to give us opinion, that's fine. Just I don't know if you're not muted, but either shout or put it on the chat there. So 5-year-old girl was sent by GP for assessment for petechial rash. Has the thing moved? Hello? Can you hear me, Rauda, or?
Yeah, I think it's
Yes.
very
It's
big.
a little
Yeah.
bit enlarged.
Yeah, let me see. I don't know what's happened. I'm just going to end the show and come back.
Yeah.
Okay.
Mhm.
Yeah, I think I can hear you.
Yeah, perfect size.
Yeah, the 5-year-old was sent by GP for assessment for petechial rash. The child has 36 hours history of fever, 38 degree, and intermittent vomiting. Someone need to switch off their phone or switch their phone because there's background. Maybe if everyone just mute, please. She also has background diagnosis of autism. You were asked by a specialist nurse to see on assessment unit. Now you approaching this child, you have straight away formulated some idea in your mind about possibility and different diagnosis. So A, B, C, D, E, F. And as I said, you need to tell the interviewer what you mean by A, B, C, D, E, F, or there. And I said the last one, A, F, G, is don't ever forget glucose. But so as you go, you assess the child, and then the interviewer will have the choice here, although they're going to apply the same scenario for everyone, but they might direct the course towards some child who is very sick, or for child who is not too sick, to test your knowledge of differential diagnosis. So scenario A, they will tell you A, patent, crying, on and off the child there. Then B, spontaneous breathing, respiratory rate 24, no added noise, no use of accessory muscles there, SATs 92. Right, okay, maybe it doesn't look like respiratory thing there, but let's keep going there. Say, well, I will check for C. Then you say, I want to check circulation, and then you say what the color of the child pale, warm centrally, but cold peripherally. Temporary fill time 6 seconds. heart rate 128 beats per minute, regular and weak pulse. Straight away, that will raise some alarm in your mind, and then you say, well, there's something here need to be done here about this child. You look at the, although you start to think about fixing circulation, the child's sleepy, irritable in handling, and respond to parents there. So I just move things a bit. I can't see the lower there. And they have particular rash. Have particular rash on lower legs and abdomen with bruises on the left arm. And you check for glucose, and the glucose is 3.9. So straight away you think, is this child well or unwell? Even ST1, you say this child is quite sick child, and then I need to manage the child immediately. Then you think, how do I manage this child? Then you move to. So this is a very sick child, most likely in septic shock. So if you need to specify, and you say to the interviewer, this is a sick child, and really, even if you don't know the diagnosis, don't even have to say septic shock, or you just say, this is a very sick child, and need to call my senior help if you are ST1. If you are ST3, you start your help, and you start your management, and you call for help. So you lead the team, you say, well, I will ask the nurse to put oxygen in this child, although 92, I try to put a cannula, and if I can, I'll send blood, I will send. So at the same time, and specify what blood tests you want, say for blood count, CRP, you say blood culture, you might say virology, you might say coagulation, you said calcium, and so on. Then you say, I want to go, this child is have circulation problem here, and I have to give a bolus of fluid, and you specify what type of fluid, especially if you are ST3, you expect, let's say, normal saline 10 to 20 ml per kilogram, and I will start antibiotic in this child because the child obviously is sick and need management here. And always when you do any action, you reassess. In resuscitation, when I was instructor, I found that the candidate, when they're stuck, they say reassess, which is good. So you always, when you're stuck, you say reassess the child and see their one. And then we see if the child still have prolonged capillary fill time here, still tachycardic, you say you repeat the bolus, check the available result, because some of them will come quickly. Blood gases, for example, you come quickly. You need to decide if what child quite acidotic, and that give you an idea how sick the child. And if you look for lactate as well, will helpful in these cases here. So the interviewer might ask you what blood tests you would send, might interrupt here, and then you need to be able to answer. What if they ask you what if you can't get peripheral line? So you might say about intraosseous line. So I need to be ready that if a child who is very sick, and you have 2-3 times, especially if ST3, and you can't get it, and there's no one else around more experienced to do that for you, then you need to go for IO there to try to give the fluid there. If you are ST1, you might say, well, I can't get it. I'm hoping that by then ST3, that my senior come and try to get it. But in all, you need to be able to say there is other way to get peripheral line. And I said, who else you need to call if the child, after 2 boluses, still quite shut down? You need to think about giving adrenaline or then dopamine or the dobutamine there here, or depends on where you work there. And you want to call the anesthetist because in this case, the child needs intubation there. If the parents present, you should allocate someone to explain what's going on for them. So a blood test might show low calcium. You need to give calcium, might show acidosis, might show hyponatremia. Need to be aware, even if they're hyponatremia, but need the fluid, you give fluid. Need about intubation, you need, if you are ST3, start to think about PICU if you have it in the hospital, or about transfer. And in the end, when everything settled down, when child, you hand over the child's care to someone else or transfer, about go back and document. And documentation is extremely important. You need to mention it to the interviewer that you will document what's happened. And you will say, well, when I have time, I'll obviously document that as part of my portfolio as a CBD then. I'm aware of the time running out quickly, so I'm going to go with that. Now, the interviewer might give you another scenario 2. They say, well, the airway is patent, breathing is good, saturation 96, child well perfused, capillary fill time is less than 2 seconds, heart rate 100 beats per minute, regular, normal pulse, alert, petechial rash in lower legs and abdomen with bruise on left arm, a glucose 3.9. That will be different. This child is not unwell. Then you need to think about differential diagnosis here. And differential diagnosis is different between child with petechial rash and sick, or someone who's not sick. Then this is not, you need to state to the interviewer, this is not acutely unwell child. Yes, have a bit temperature, vomiting, but then you have to think differential diagnosis, viral infection, ITP, popular leukemia, or safeguarding issue concern here. You need to be able, especially if you are ST3, formulate a list of investigation, discuss with the senior, especially if you have safeguarding issue here. And in this case, maybe you might say, well, I don't really need to, if you are ST3, need to call, you might state that I don't need to call my senior acutely, but I want to discuss with them way forward. Communication with parents and documentation, especially if you're suspecting safeguarding, remember to use body map to draw things there and try to include it in your portfolio as well. Do I have time for a quick look at the last one quickly?
Yes,
Yeah.
we do have.
Okay, well, I have a couple of more minutes anyway, and then we'll have more than a couple of minutes now.
Oh, yes.
Okay. So that's really mostly this. Now, the second case, you were called to ED for standby call. You were told a sick 3-days-old baby on the way to the hospital. Expected time arrival 5 minutes. So you have 5 minutes. The interviewer might ask you what you want to do with this 5 minutes while you're waiting there. Again, depends whether you are ST1 or ST3. ST1, you straight away on the phone, you want to call your your senior one. In cases of these cases, usually the hospital will call the most senior person anyway. But if not, you will call someone senior. What you want to call for help. Even if you are ST3, you might say, well, I want to let my consultant know about it, especially if it's a good time of the day, not at 3 o'clock in the morning. Think of differential diagnosis. This is a 3-days-old baby. You might get more information from paramedics on the phone while you're waiting, what the condition and how of the baby. Then think about, okay, what differential diagnosis I think of baby. And you can again vocalize that to the interviewer. I say, well, I would start to think about it more. Put on the board resuscitation. I don't know if people familiar with the acronym wet flag or wet flag, which basically you put your calculation for resuscitation, W for weight, E for ATT size, and you try to start to talk about here about fluid, about glucose, and so on. So you put all the your calculation on whiteboard. So when the baby arrives, you're already aware of it because you say 3 days old, so the child will be 3.5 kilograms, something like that. Then I could calculate on that basis. The ATT will be about 3.5, for example, the same way. energy for how many joule I need to, if I want to shock him, how much fluid I need to give him, and so on. So that's when your baby arrived, you were told information here on the phone that baby was discharged from maternity yesterday, was born at full term by emergency cesarean section for failure to progress, good condition at birth, birth weight 3.7 kilogram, breastfeeding. So has that add much to your differential diagnosis, you think? Maybe, maybe not. We'll see there. So in the arrival, the airway were patent, breathing was gasping, and being bagged by paramedics, and oxygen saturation was 88%. So really here, the first thing you want to optimize his breathing. You want to make sure that, so maybe you might take over the bagging from the paramedics, try to put the laryngeal airway, or while you're waiting there, just try to improve the oxygen saturation here, there. Well, and obviously you might want to, in that case, call the anesthetist if you are not able to manage the intubate the baby yourself there. Then your bag and mask here, then sorry, there's next one. There's small there. Sorry for the small punt there. So with after you're fixing AB, then you were talking about assessing circulation, pale, capillary fill time 4 seconds, weak pulse, heart rate 160 beat per minute, no murmur. Then again, you want to try to establish a line here. You just want to say, can I get the peripheral line? Is there any possibility to get umbilical line in this baby? Because maybe some cases after 3 days, you might still be able to do that if you have the experience. But again, remember, if you're ST1, don't mention it at all because you don't have the experience. If you're ST3, you might say, well, I have experience in neonatology and I think I can do it while I'm waiting there. D was just responsive to pain. There is no rash and glucose 1.5. So the baby have hypoglycemia. If you have a line, peripheral line, so will be your priority. Bag and mask, 2 persons, you might say, might improve the breathing and here technique. If I use 2 persons with jaw thrust there, call the anesthetist. Circulation, I get a venous line. I want to give bolus normacy line here. I give bolus 10% dextrose because I have hypoglycemia and I want to fix that. Then if you haven't already called your senior, you ask someone else to call them while you're doing all this one, another call for help with updated information. They might need to, they might give you advice on the phone here without the need here. Then while you're doing that, you really need to be saying, well, I want think here about differential diagnosis and specific treatments. With these babies who 3 days is who collapse like this or what and well, you think, is it cardiac? Is it metabolic? Is it infection or others? Cardiac, most of them will be duct-dependent conditions, which basically baby have a cardiac condition, but because the duct was open in the first day or 2, the baby was well when he discharged home. When he gone home, the duct closed, then you present. And your priority here to keep the duct open. And that's why the idea of prostaglandin, you give it in these cases. So if you have experience T3, it looks very nice to tell them that you're aware of it, and it will add to your marking here. Metabolic here, you might be metabolic condition, and then use obviously blood glucose. You have hypoglycemia, if you have acidosis with this baby, and there's no as unlikely to be cardiac, then you think, is it metabolic? What do you do? Give fluid, make sure fix glucose. Might need to give sodium bicarb in this case here. Well, I'm waiting. I need to call then the metabolic consultant in the children's hospital and take advice from them. Infections, ask whether the mother had history of GBS here, because again, useful. In general, all these baby will receive antibiotic because we need to treat infection. So infection and the baby got sick quite quickly, that can happen here. And you might be the case just CNS, just maybe have brain abnormality, and just or you might have muscular abnormality. But I might have as a genetic condition. But that's actually, you're not going to change much really in these cases here. So it's you do the best you could do. But what your interviewer want to know that you could manage, you're thinking while you're stating, and we have a common sense approach and reasonable differential diagnosis in these cases. That's me.
Perfect in time. We only have like 6 minutes left for questions.
Any question?
Nothing from the chat. Anyone would like to ask any question regarding clinical thinking station? I'm sure you have some, please. Yeah.
Okay. Hey, thank you so much for the lectures. I'd wanted to find out, he talked about another call for help, but I didn't really get who we should call, you know, based on the information that we have. That I don't know. That part wasn't very clear to me.
I mean, in practice, you might have already called, let's say if you are ST3 or ST1?
ST3.
ST3. I mean, if I'm consultant usually, and then you're ST3 call to casualty, you call me, let's say I'm on call from home, and you say, well, I expect baby to be sick who's coming here. We quite a lot of times sometimes say, well, okay, see how it goes, because it might be something you could manage if there's and then or I'm on my way, but I need to get dressed and go, and it might take me about 20 minutes to come to you. So by the time the baby arrives, you get more information about the baby, and you say, well, I can't, for example, feel the pulse, femoral pulse on this baby, and the baby quite unwell. I might say, you might ring me, and I say, well, give Prostin here. In this case, I'm on my way, but give Prostin while I'm waiting, or call the anesthetist while I'm waiting, or give another bolus fluid. So another call for help, really, just for update the consultant with your the condition of the baby, and see if there's anything can be done while you are waiting for the consultant to arrive. You might actually, at the same time, you are probably asking your junior doctor to try to get a line, or you might direct the nurse to put oxygen on the baby. And at the same time, you have already established line, but you want to move forward, then you ask for a call for another help. That's really just with the updated information. It might be not be your consultant, might be called for help for anesthetist.
Okay, thank you very much. So it's dependent on, you know, the case and you know, the problems I encounter while doing the resuscitation then. Yeah,
I mean, it's always, I mean, when things get quite tricky, and you might just get help because you've been given a couple of members of the staff with you, and you need more people to deal with the baby. You might be calling for help from nurses from pediatric ward, for example, if they're not giving, if you're told you only have one nurse in casualty. So it's not really, it depends what the case you have and what the scenario you're given. So you call for help. This is just, I gave example of this baby. If I'm in casualty and this baby present, I need really as many people as possible and as senior as possible. And I need anesthetist definitely. If I'm not capable of intubation, I will intubate the baby because I'm quite experienced. But if you are not experienced and baby quite sick, I don't know if ST3 would have enough experience to intubate sick baby, but then you need someone to do that for you, especially if the oxygen, you can't get the oxygen up.
Okay, thank you.
Okay.
Any more questions?
We have a couple of questions. I think someone was asking about red flag and has been answered. And someone is asking about chronic cases in clinical thinking.
It's unlikely that there'll bring chronic cases to clinical thinking, most of the time will be something acute, not necessarily acute, very ill, but acute cases. Will be either presented to casualty or assessment unit or in the pediatric ward. Chronic cases not usually presented because they want someone to be safe to deal with acute cases. Chronic cases doesn't pose the same risk.
There is another question. Someone asked what I should say in safeguarding cases, clinical assessment, ensuring child safety, talking to parents, start to rule out medical causes, inform senior and documentation. Is that enough?
Yeah, I mean, this is a difficult one. And again, depends on the level. If you are ST1, obviously you will expect your senior to come, someone more senior to come, and because you don't have really experience to definitely talk about. So I wouldn't be as ST1, you'll be aware of it. You could say that to the interviewer. I was thinking here's a safeguarding issue here, but I wouldn't be someone who go to the parent and speak to them. But if you are ST3, you have to say that I can't find any clinical cause or physical cause for this child bruising. We would need to send some blood, obviously, some investigation, but we need to look for different causes. And if the parent insists on, and this parent usually say, what do you think you might cause it? You might say, well, the child might have low platelet, might have can't have problem with the clotting, but we have to look as well for other possibility, like this has been done to him deliberately. It's difficult, but you have to face it. There's no point going around the bush and you have to document that. Parent will use ambiguity in communication as a defense sometimes in cases when they go to court or to go to social services.
I'm afraid we don't have much time for further questions. Rauda, do you have anything in the chat yet?
I think we are just about in time. Thank you very much, Dr. Al-Jarad. I appreciate that very much. Thank you.
Good luck, everyone. Thank you. Bye.
Thank you.
Okay. Thank you, Dr. Al-Jarad, for the nice and stunning presence. Now we are moving to our next session, which would be presented by Dr. Khalid Abdel Hafiz. It would be in leadership. Khalid is ready. Yeah, so governance and leadership. Khalid is one of our own. He's been through this process before. He's now ST8, nearly done. He's sitting this year, and he's been mentoring many applicants through the recent few years. And he's a proud BSAPCH member. Nice to have you, Khalid. Hello.
All right. Can you hear me now?
Yeah.
Oh, perfect. Perfect. Thank you so much. Thanks to all BSAPCH academic office for doing this for the ST1 and ST3, and I think thanks also to Dr. Bassam. I think it was fascinating lecture from an experienced consultant. My lecture is a little bit dull, I would say. And so I took on this hard task to explain a little bit about clinical governance and leadership. And I think this will be a question, or at least an attribute that you would be expected all to show whether you are applying for ST1 or ST3. So so it's gonna be a lecture about just explaining what is clinical governance and leadership. Just following on your intro, I'm ST8 Pediatrics. I've been through this process before, just like all of you guys. I applied, I mean, I think it's many years now ago, and I joined from ST4, and I've been through this interview process, and I know it can be a little bit daunting, to say the least, kind of experience. So let's start. Just let's make sure that the technology works. Is it moving? The slides, are they moving?
Yes.
Perfect. Good. I will try just to make it a little bit more interactive. That's okay. So I know that some of you have put your camera on, but most of the group is a shy group, which is fine. But if you don't mind, I might be a little bit, I might ask randomly, just for a little bit of participation, if that's okay. So anyone on the call, I might just call your name if that's okay. So basically, what we will try to cover today is just to show you what is really is expected from you to show when it comes to leadership and a leadership attribute and understanding of clinical governance, and to explain a little bit how to come across as a leader, and is just also to show you an overview of what is clinical leadership and what are the human factors that you need to show as a pediatric trainee or a potential pediatric trainee. We will be discussing the boring bit, I would say, which is about clinical governance. And I know most of the group would be coming from an IMG background, which is basically we don't really learn a lot about clinical governance and clinical governance pillars back home. So just a little bit of explanation about clinical governance, and hopefully just to help to end that with an example how to show that in basically in an examination or interview scenario. So basically, when it comes to the ST1 and ST3, obviously the stations are changing throughout the years. When I did ST4, it was face-to-face interview, and the stations were completely different from now. But I think it's still the same when it comes to the expectations. As ST1, you would be expected to show leadership skills when you talk about your career motivation station, and also in your communication station as well. And I think throughout all of the stations. And in ST3, yes, there is one dedicated station to leadership and clinical governance, but also you will be marked in all stations for this attribute. And basically, I just wanted to show you what is really expected from you. So this is coming directly from the the RCBCH curriculum. You can see here that this is basically on the curriculum, that the key capabilities for you as a leader, that you need to show that you are a safe and effective leader. And because this is the level you'll be joining as ST3, and ST1 is level 1, but obviously it's almost the same kind of key capabilities, and just to show that you are a team member, like an effective team member. But it's just go through the slide, and basically you are expected to also take an active role in promoting the use of healthcare resources, retain leadership qualities in a situation of stress and conflict. And that's why you might be a little bit challenged when it comes to like clinical thinking station or communication station, because this is where there is a little bit of stress or conflict, and this is where your leadership qualities would normally show. So this is what will be expected from you to show. This is just from the curriculum, and this is not only for the interview, also when you start working as an ST1 or ST3. This is also from the personal specification. And again, you can see here, I'm not sure if you can see my arrow here, but you are expected to show a lot of values, including empathy and sensitivity, which is really one of the qualities of an effective leader. But also here, you are expected to continue to demonstrate the understanding of NHS management and resources, and basically evidence of leading clinical teams. So yeah, so basically leadership and clinical governance will be everywhere in the stations. This is directly from the ST3 applicant guidance, and again, the interview question will be designed mainly to show that you are aware and understand the role of governance, and the scenario might not be directly clinical, but still you will be just tested on the spot, how to, for example, manage situations of there is like short staffing, or even a short leadership in a patient management or critical incidents, and a drug error, a complaint handling. So this is all what will be expected from you, and we will run through one example later, but I just wanted to show you what is really expected from you, because it might be a little bit vague and not really clear what will be on the station. I just thought to show you more of like kind of an insider tip when it comes to the scoring framework. I will be sending this lecture later to share with everyone, but this is the marking sheet, or it used to be the marking sheet at some point. You could see here, when it comes to the governance and leadership station, you'll be marked against your attitude and knowledge of. You'll be expected to show attitude and knowledge of the process, for example, in complete process, if there is a question like that. General approach and listening skills. The patient safety always is important, and I would suggest that you start with that in every question, obviously apart from the career motivation question, but basically in every question, just make sure that you say, I want to make sure that the patient is safe, or to ensure patient safety, whatever you the way you want to say it. Also, it's important to show that you will be escalating and documenting and supporting your team, the parents, the patient, the staff. But it's not only in the governance and leadership. Again, you could see in the clinical thinking, you will be expected to show some teamwork and leadership skills. Even in the communication station, you will be still expected to show some mature communication skills. So it's everywhere, and this is what I wanted to show. Basically, it's we have kind of different opinions or different approach to what leadership is, and it's really important to make sure that you really understand what is a leader and what is a manager. And this is again coming from the Royal College expectations, or Royal College lectures, previous lectures. You are expected to inspire rather than instruct, and to set the standards for everyone rather than just expecting people just to do it. And I think every one of us might have in mind a role of a leader or a role of a manager that you might be annoyed with at some point of your life. But basically, a leader is a little bit different. What you expect from a leader is to be someone who's can be a role model to you, generate some enthusiasm, demonstrate you a vision for the department or even the small team. And at this level, what you would be expected is just to show some of these attributes, rather than just sit in the back and ask everyone to do the job for you. It is important at some point to show that you will be delegating, so delegating tasks to everyone, but also you'd be expected to start the work yourself. And this is a little bit different style. Everyone will have a different style to become a leader. So so in situations when it comes to, for example, setting an audit or a quality improvement project, your kind of a style or leadership attribute will be a little bit different. For example, you will be more of an effective leader, right? So more of an active behavior. Whether if you are more of like in a clinical scenario, you might be a little bit more sitting in the back and asking, for example, the junior doctors to do some work for you. So the style of leadership will be really different to depending on the scenario. I always like this kind of code when it comes to who's a leader, and I think this sums it up all. It's a leader is someone who knows the way, so you need really to a little bit of like a layer of knowledge, so to know a little bit about what is really happening, what are you leading on, so clinical knowledge basically, but also goes the way and then shows the way. So and this is leading by example. So you don't have to just know to be a leader or do the work to be a leader. You need also to show it to everyone around you, and that can be applicable to all the team members or the allied health professionals, doctors, nurses, front desk receptionists, everyone around you will be looking at you as a leader, and you need to show that in the interview. I'm not going to go through the definition of leadership. It's just there to capture the essence of leadership, but it's kind of what you'll be expected is to collaborate, to show that you are collaborating. You are a team member. You are supporting everyone around you. You are making informed decisions. You are taking the responsibility on. So one of the tips I would say to you to show this attribute is to use the word I rather than we every time you answer one of the interview question. That I will be doing this 1, 2, and 3, and I will be asking 1, 2, and 3. I will take on 1, 2, and 3. I will delegate this task to rather than we will be doing this task or process basically. So I think this is just important to know that all of you on this group or in this audience, you are a leader. You have shown without a doubt an attribute of a leadership. You know what it takes. If you have managed any patient in your life, you are a leader, because this takes leadership skills to be able to stabilize and manage a child, whether that's in the neonatal unit, in the delivery suite, in the emergency department, in the resuscitation scenarios, or even in inpatient. Even if you are managing a child in the outpatient, you are showing a leadership skill. So it's everywhere. And I think this is, if we go more a little bit practical, so this was like the theory bit. What I'm expecting from you to do is I want you to show that you can collaborate, right? So this is really important. So let's say, for example, in the clinical thinking question, you will be expected to show that you can ask for help, you can communicate the handover back to your consultant when they come in. If there is like a complaint or this is like a drug error, that you will be able to lead the team towards a common goal, which is making sure this is not happening again. It will be expected from you to highlight the positive impact of on patient outcome. So let's say if I take this role on, I will be improving, for example, the patient safety, or the waiting time in the A&E, for example. This will be expected from you, just to show some impact on patient outcome. And when it comes to the career motivation question, and I know that the audience is a little bit mixed audience when it comes to ST1 and ST3, you will be expected that it is important to show that you have been involved in quality improvement projects and creating kind of implementing guidelines. And this is another way to apply and show leadership skills. And again, all of that will be, you will be marked against. Another one is to emphasize your role in leading and motivating the team. And I think this is important when it comes to the questions like, tell us about an audit that you've done, or if there is, for example, like one of the questions came before was, you will be given like a kind of a handover list with 5 or 6 patients on the list with different needs. And you will be expected to see if you are able to manage the floor and motivate the team around you to, for example, finish before the handover time, which is like midday, for example. And obviously clinical thinking and clinical decision making station as well. You'll be expected to show some leadership skills. So this is basically what will be expected from leadership. We will be discussing that in more of a practical example at the end. I know it's a little bit more of a theory, but I just needed to show you what will be really expected from you. Rauda, are you following the chat? If there is any question on the chat, please let me know.
We are all following the chat. Still no question.
Perfect. Lovely. Let me just minimize this first. Right. When it comes to clinical governance, and I know some of you might, and I'm sure that most of you have been involved in clinical governance, whether you know it or not. I'm sure all of you would be. Governance in general is generic term, and we as clinicians normally just shy away from any words, big words when it comes like to governance. But basically, it's just how society and how groups organize to make decisions. So it's just basically the way that organizations or countries are managed at the highest level and the systems for doing this. And basically, all we need to do is like, or the governance do, or the business models or companies, they just need to promote, maintain the highest standards of governance to make sure that the system is working. And to govern is it is an art, but also it needs to be standardized. So just let me see this one. Yeah, to get to the to improve the patient care, and the NHS. I know this is a very long definition, but and you will not be expected, obviously, to know this, but it's just to highlight it is more of a framework. I know someone at some point when they were interviewed and asked that question about clinical governance, the only thing they could think of was audits, which is true. Audits is part of clinical governance, but it's just the answer did not capture the complexity of the clinical governance or and how important the clinical governance is. It's basically more of a framework rather than just one thing. It's a framework where NHS organizations accountable and continuously improving. And it's a framework to improve the quality of the services and make sure that they maintain high standards of care, and to maintain its improvement and to make sure that it's flourishing all the time. And in basically just to make it simple, it would be just to do the right thing at the right time by the right person, and make sure that it's evidence-based and it's patient-centered. So this is the clinical governance. And I might, before jumping to the next slide, can I ask the audience what can they think? What are the components of clinical governance? And I would really welcome anyone to open the mic and shout out, or even put it on the chat, if that's all right. Maybe 20 seconds. If no answer, I might just pick someone randomly, and I might pick some names that I know already. So just think about what is clinical governance, what aspects of your work or daily work might fall under this umbrella of clinical governance.
Audit or like QIP.
Perfect. Audit or
Quality improvement project.
Lovely, lovely. So absolutely. So audits and quality improvement projects are absolutely important part of the clinical governance, and that's basically to make sure that we are maintaining the quality of the work that we do. I can see Sarah wrote about guidelines. Perfect. Sarah, can you switch on your mic, just your mic, and just tell us a little bit how can guidelines be a part of clinical governance? And you're absolutely right. Guidelines are absolutely part of the clinical governance. You can just shout or write it in the chat if that's okay. That's fine. Someone put a training and education. Absolutely. Whether you know it or not, the trust or the department are putting training and education as part of the clinical governance. And in every kind of report, when they report the clinical governance activities in any department, training and education will be part of it, and it is a mandatory for any department to maintain training and education for all of the staff, including nurses and doctors. So it's not more of a luxury; it's a mandatory thing to do. That's lovely. I might just go to the next slide and show you the pillars of clinical governance, and this is very basic. So I'm expecting all you to know this, the pillars of clinical governance, and at least to be able to name the pillars without explanation or without more details. And it's really important. It's a level of, let's say, foundation doctor to know all of this. But this is the 7 pillars, and we will be going through them in details in a second. But all I wanted you to know this is clinical governance is not only clinical audit, and it's not only clinical guidelines, which falls below the clinical effectiveness, but also research is clinical governance, being open, and the duty of candor, and including the complaint process is a part of clinical governance. Education and training, as someone put in the chat, is part of clinical governance. Risk management, when it comes to datics management, or what we call now BSAPCH, is part of the risk management, part of the clinical governance. So it's, and in the interview, you'd be expected at least to show that you understand the essence of clinical governance. You might not have a direct question about it. You might have some people had this question before, but you'd be expected more to show that you understand this bit. So what I would suggest to you is to keep this slide in the back of your mind when you answer any question. So try to say something about being open to the family, for example, if there is any error happened, to be able to show that you understand the datics process, that you want to make sure that everyone around you will be educated and trained about the incident, or about or even to educate the patient or the family, to make sure that you maintain the quality of your work by doing clinical audit at some point, or asking someone to do it, to make sure that you stick to the guidelines, or even develop a guidelines if you think it wasn't effective enough, and to apply evidence-based medicine based on research, and even to demand research in this area. Lovely. I can see more questions. Perfect. More lovely answers. Risk management, openness, and insurance. Perfect. I can see the group is I think most of you really understand the essence of clinical governance, and I think what I wanted to do is basically to show you how to apply this in a scenario, hopefully in the interview. The next slide is mainly about just examples. So guidelines, protocols, even the safety alert, the huddle that we do, the handover in the morning and midday and the night shift, the incidents, the transparency, even the prescribing and the medical records, like the electronic medical records or developing electronic medical records are part of the clinical governance. Documentation, the communication, the referral pathway, the SOPs, the guidelines, all of these are part of the clinical governance. So it's almost everything that you do in your day-to-day work is part of clinical governance. And what I'm just trying to say, if you go back to the marking sheet, which we might go back in a second, all of this, you will be marked against if you say that, yes, you'll be sticking to the guidelines, all right? They understand the clinical governance, they understand the patient safety, they do understand the complaint process. So this will be your assessor or the assessor on the interview going through their mind. And I've been on one of the mock interviews before, and I know that this is how we do it, because there is just no time. You just go through the marking sheet and make sure that the applicant at least understand the clinical governance. So I want this to be a little bit more interactive, if that's okay, guys. So we'll just go back, actually. Let's say, I'm not going in details, but let's say in your clinical governance and leadership station, the nurse came to you saying this patient has received an extra dose of gentamicin to a baby who's only 1 day old, coming with respiratory distress. And how are you going to deal with this situation to show your leadership and your clinical governance understanding? And I want just even random answers will be fine at this stage, but if anyone can turn on the mic and just say what are they going to do in this kind of scenarios, that would be great. So a child, baby, received an extra dose of antibiotics or wrong dose of antibiotics. How are you going to deal with the situation to show your leadership attributes and clinical governance, understanding of clinical governance? Anyone?
Okay, maybe I give it a try.
Go for it.
Okay, thank you.
What's your name?
My name is Oba.
Hi, Oba. Okay. Yeah, go for it, Oba.
So what I'm going to do, thank you for the opportunity. What I'm going to do for this baby, I want to immediately go and review the baby, ensure that, so I'll review the baby following the ABCD approach, ensure that the baby is safe. And after reviewing the baby, I want to quickly know the dosage that was taken and also escalate to the consultants. While doing that, I ensure the baby is characterized because of the effects of gentamicin on renal function. I want to also ensure enhanced monitoring. Then based on the leading from the consultant, we may have to give an antidote, pyridoxal phosphate, if there is need. Then we are also going to have a duty to inform the parents and also.
Can I stop you there if you don't mind? Okay. So absolutely. Yes. So the first step is absolutely spot on. It's basically patient safety, to make sure the patient is safe, isn't it? And to make sure that you prioritize the patient care. And this is, we will be discussing all of these steps in a second, but I just wanted to make sure that you to commend you for the first step. And I think this is really important, to show that you prioritize patient safety above everything, that you are not distracted by the drug error, right? And you still want to show that you are a safe leader of the team. Lovely. I might ask someone else, if you don't mind, Oba, just to go to the second step, if that's okay with you. Is that all right?
That's okay. Thank you.
Just to make sure that everyone is been given like an opportunity. Anyone else to tell us what's gonna be done next?
Hello?
Yes, go for it. Who's there?
Yeah, I am Dr. Fatima.
Hi, Fatima. Okay. Ilham or Fatima? Sorry.
Fatima.
Fatima. Go for it, Fatima. Okay.
Mm.
So what are you going to do next?
Next step, I inform my senior and inform the parent about the error and what I will do for the child.
Right. And what are you going to tell the parents at this stage?
Like I am telling, by mistake, he's got 1 dose of gentamicin. He should not take this dose. And what I will do for him, like I will do, the step what I will do, like I will take a hearing test. I will refer him to a hearing test, and I will do also blood monitor for gentamicin, and I will observe him.
Lovely. So you will be sharing that what are you going to do clinically with the patient? That's absolutely one step. Lovely. Are you going to tell them anything else if in case they are upset or they are really annoyed of what happened? What are you going to share with them?
Yes, I will tell we'll avoid this mistake by we are doubling checks and we highlight this and we'll doubling check the dose and we'll do the meeting with the head of the department to know what's the cause and the risk, and will not do this again.
Lovely. So you will be explaining the investigation process. You will be explaining the complaint process to them as well, and you will be showing. So you'll be open with them about what happened. Perfect. That's absolutely good. And as someone said on the chat, you will apologize, right? You will say sorry, and which is really important, isn't it?
Yes. First, I apologize of behalf of my team for this error like that.
Absolutely. Well done, Fatma. Thank you so much for that. Right. What will be the third step? We will be going through this again. I just wanted to give everyone an opportunity to do it. So, Sarah Ismail, you said incident report. Can you turn on the mic, Sarah, and tell us a little bit about incident report and what's going to happen, if you don't mind? Or Iman Ajali.
Hello, I am Sarah. So,
hi, Sarah. Okay.
Yeah.
What are you going to do next?
So I will tell the parents that I'm going to do an incident report.
Perfect. And how are you going to do this?
So there is incident report forms.
Lovely.
So I will fill one of them. And then also I will tell the parents about the rights to complain if they want.
Perfect.
And also I will ensure them that we are trying our best not to repeat this mistake again, and we are going to revise why such a mistake happened, and maybe we will do checklists or audit or something in higher levels to make sure that these errors are not going to be repeated for another babies. And I will not mention to them, if they ask for specific names, I will say that I'm not in a position to tell them about who did this specific names or something like that.
Well done. So Sarah, basically you're going to make sure that this mistake is not gonna happen again by doing a datix. What are you expecting from the datix? So let's say you put a datix now. Do you know what's gonna happen in the future? Who will pick up that datix? Like, for example, it's okay if you don't.
There is a committee for they are going through the incident reports.
Lovely.
I think the management, or actually I don't know specifically, but I know that there is a committee who are sitting and revising these incident reports.
Perfect. No, that's absolutely perfect answer. And I think so far all of you guys have basically having like a complete marks for your answers, because basically you are showing leadership, you are showing that you understand the clinical governance. Can we just go to the next step? So let's say you manage the baby, you made sure that you looked at the BNF or local guidelines for gentamicin adverse effects, you were open and you discussed with the parents what's going to happen and what will be the ethics and complaint process and what's going to be the clinical management for their child. Then you went through the safety bit and explained and but put on a ethics and explored how did the mistake happen. What would be the next step, after wrapping up all of these steps? Do anyone know what's going to be normally the final step? And anyone is welcome to answer.
Activate duty of candor.
Okay, so the duty of candor is absolutely spot on, which is basically it will be the second step, isn't it? Yeah, second step to be open with the parents. Iman mentioned something about being of documenting, pulse, SHO clarification, and pulse again. Yes, so all of this absolutely spot on. I think then the last one, and I will be sharing my slide now, is learning and improvement. All right. So I would like all of you to make sure to mention this. This is just more of like a framework of your answer. Okay. You can see like you have covered them all in your chat and to everyone who spoke up as well. It's basically assess the child. So the first step is immediate clinical response. All right. So every question, always think about patient safety first. Patient safety first. It doesn't matter if you are busy, whatever the scenario is, you want to make sure that the patient is safe. If it's about safeguarding case, you want to make sure that the rest of the departments is safe as well. So always start with the clinical response. So assess the child, close monitoring, consult your seniors, notify the authorities if there is if needed, and manage the child. If the child needs anything, antidote or anything, just manage the child. So this is the first step. Second step would be about communication and being transparent with the parents and duty of candor and explaining the risk and explaining the steps that you're going to be taking next, which will be the ethics and also about the complaint process, as many people said about the pulse. The investigation and analysis will be the next step, which is the ethics. Now we call it BSAPCH, and I encourage some of you just to Google it later. And it's basically, it will be replacing the critical incident, just to show that you are up to date and up to speed with NHS changes, and review the medication administration process. So for example, for this child was a gentamicin. Let's say, why was it given this way? What did happen? Make sure that you mention that you understand the Swiss chess, Swiss. I always say it wrong. Swiss cheese model. Basically, is to make sure why this mistake has happened in the first place, and also. The last or the final step would be, how are you going to learn, reflect, and improve the service based on this incident? And it's more of a cycle. So it happened already. I'm going to manage. I'm going to be open about the mistake. I'm going to investigate the mistake, and I'm going to reflect and learn from the mistake. Whatever the scenario, always keep that framework in the back of your mind, right? And you can always say something about putting that in the safety huddle, maybe generating or starting like a simulation scenario, just to make sure everyone is aware, analyze or even change the protocol, or put that in the clinical governance or morbidity and mortality report. There is a lot of ways to share the learning outcomes. So in this scenario, so just going back to the leadership and clinical governance, just to see that if people just grasp a little bit about leadership and clinical governance, can anyone tell me what are the leadership attributes you have shown with answering this question? Anyone, even the facilitator can answer, by the way, Ilham. What do you think you can, what are the leadership attributes you would say whoever managed this case has shown?
Sorry, I've just been lost for a while. Okay, so leadership, as you explained, is multitask and how you manage the critical incidents, how you deal with the situation as you have a parent, you have a sick child, you have your manager.
So
you have
what are the attributes? So basically, what is the qualities of a leadership that you have shown in this case? If you understand what I mean. So you said something about talking to the parents. So an effective communicator, right?
Yeah.
Good communication skills. Perfect. What else? Anyone in the chat can answer. It's fine. I'm monitoring the chat. Good communication, yeah.
There's accountability, teamwork.
Accountability, absolutely. Enduring safety, transparency, perfect. So exactly. So this is the bits we were talking about. It doesn't really matter. You will not be asked about show us how an effective leader you are. You're just going to do it. You're just going to show it by answering yes, accountability, effective communication, collaboration. But what I want all of you to focus on, because I'm sure that all of you will answer the first three bits, it's the reflection, right? And there is a lecture later about reflective practice. But just make sure that everyone at the end of the question to wrap up the question by saying, I am a reflective leader, or I am a reflective clinician, and I want to take some learning points from this case and share it with everyone. And this is the attribute they are looking for. And I think it's really an important attribute. So going back to the clinical governance again, right? This is a cheat already. What are the clinical governance components that has been shown in this case? And again, anyone can answer. Clinical governance. Just try to remember the 7 pillars we talked about, right? What are the clinical governance? And let's just try to cover the 7 of them, if that's okay. Perfect. So first answer was risk assessment and management. Absolutely. Openness and transparency. Perfect. Lovely. What else? Local guidelines. Perfect. So clinical effectiveness. That's great. Patient safety and education. Training and education. Perfect. Lovely. So absolutely. I think you're all spot on. And again, I just thought to show it again. So firstly is basically you are showing clear roles, and so the accountability or the clear roles and responsibilities is part of the clinical governance. So as a doctor in general, you are expected to show that you understand patient safety, that you are adhering to administration protocol. There was some comment about training and education, and yes, you are identifying in this question what are the knowledge gaps and what are the training needs, and to take steps to address them. Information and documentation is really important as well. I'm just going through. So also what you can mention again in your answer, that you're going to see if this is more of a recurrent theme. Drugs error is a recurrent theme, and you can suggest a clinical audit to improve it. The other pillar was about risk management, and again, root cause analysis of the error is really important, and that's why this is where incident report is important. And you can say this is a part of the clinical governance. We need to make sure that we manage this risk appropriately, and ethics is the way to do that, which will be investigated, obviously, and something will come out of it. Clinical effectiveness, people in the chat mentioned about guidelines, and yes, it's just to make sure that we have guidelines to start with, and we stick to the guideline or the process to make sure that the patient is safe. And the last thing is about patient and public involvement, isn't it? Or about openness, to be open, to be transparent with the parents. And this is, and again, you see, in one scenario, leadership and clinical governance can be covered. I just wanted to show you like more of one example. And there is a lot. Before we summarize and conclude, I just wanted to make sure that there is other factors, obviously, in any kind of scenario in the interview, which is human factors. And I think this is not only in the interview, but also at work as well. There is a lot of human factors will contribute to the errors or contribute to your clinical work, and just keep that in the back of your mind, that it's not only about you, it's also there is a lot of other factors around you that will contribute to the patient outcome. Make sure that you show some of these human factors, like your understanding of some of these human factors when you answer these questions. Like, again, communication always comes first, especially for us as coming from like an overseas background or as IMGs. You are expected just to show that you are an effective communicator. It's not about language barrier here, don't get me wrong, but it's about understanding what is how can you be an effective communicator to the patients and the team around you.
Sorry to interrupt you, just 5 minutes left. If
Perfect, that's absolutely the time I need. And again, to show that you are emotionally intelligent as well, that you are learning from mistakes, and you are aware of the challenges around you, including unfamiliar equipment or tiredness of the team or poor staffing. This is just to mention some of the human factors. So basically, in summary, clinical leadership and clinical governance are fundamental. So it's fundamental for everything we do in our day-to-day work. And this concept, you can show these qualities in every station, right? And when you practice, hopefully in the interview, when you practice for the interview, just make sure that you cover all of this. Try to cover all of these attributes and show the assessor that you are an effective leader and you understand what is clinical governance, and to make sure that you illustrate your experience and highlight the positive impact of your qualities. So yeah, I just wanted to wish you all best of luck, and I'm sure that you will be all great pediatricians. And I think you've got this, right? You've got this, guys. Good luck.
Thank you, Khalid, for the very rich presentation, and we explored the leadership and governance with you. So if anyone have any question, please feel free to ask Khalid. Yeah, got something better?
Okay, thank you for the lecture. I want to find out who should inform the parents in the cases of drug error or child abuse. Who should inform the parents? Thank you.
Sorry, the question is about drug error or child abuse? Just a little bit different.
Okay, for drug error, who should inform the parents? Thank you.
Yes, so you are expected to inform the parent at the moment that the drug error happened, and this will follow. The step when you ensure the patient safety. You would be expected to come across, and if you are comfortable, obviously, if you are an ST1, you might be asking your senior to come with you. As an ST3, you would be expected to lead on this and to say that I'm going to inform the family. I'm going to start with reassuring the family that their baby is safe or the kid is safe, and then I will be explaining in a very honest way what mistake happened and why did it happen and what what are you going to do to manage the patient, and what steps are you going to take next. So this will be expected from you to do. Isra is asking, yes. So DATEX itself is more of a generic name, and different trusts use different names. But the process itself, it used to be critical incidents reporting, is now changing to something called BSAPCH. Let me just, because it's a new one. It's a patient safety incident response framework, right? So this is the new term. It's only started about 4 or 5 months ago, and many trusts have already started to implement it. Lovely. Thanks, Aya. Cheers. Any other questions? Sahar, yes, I think it's being written there. PSERV. Right. Lovely. Perfect. So best of luck for the rest of the day, and hopefully you will smash it.
Thank you, Khalid. Have a good day too.
Bye-bye.
Thank you. Now we are going forward in our day to Career Motivation Station. I would like to introduce Dr. Monica Nigoita. She's a community pediatrician in Leeds, and she's a college tutor, and she's taken part in ST1 shortlisting this year. She's interested in medical education and taking educational lead role in Yorkshire School of Pediatrics. And she's been trained in Romania, Republic of Ireland, and in the UK. So she has a very wide range and thrilled with experience across different health systems. So welcome, Doctor.
Hi. You can hear me? Is that right?
Yeah. Lovely to have
Hi,
you.
everyone. Thank you for the nice introduction. And thank you for the invitation to speak to you today about this career motivation station in your pediatric training interview. So first, I should say that I'm very happy to answer questions as we go along throughout the presentation. I'll try and keep the chat at the front of my screen somehow. But if I miss any questions that are coming, just interrupt me and tell me as they come. I'm very happy to do that. Or you can raise your hand or unmute and ask me as I go along if something that I say maybe needs clarification or anything like that. To start with, I have a couple of questions for you all, because I want to know who's in the room. First, I'm so impressed with so many people in this meeting, but I want to know who's in the room. So raise your hand if you have worked in pediatrics already anywhere in the world, and maybe type in the chat, where have you worked? Because it would be interesting to see. I can see lots of raised hands, a few raised hands. Yeah, and type in the chat. Let's see. Yorkshire, someone worked in Yorkshire. Hi, Sudan, Saudi Arabia, Newcastle, Luton, Arab Emirates, Nigeria, and Yorkshire. Hi, and Ireland. Hello. I'm excited about people who have worked where I've worked. Someone in Aya is working in Saudi Arabia. Hello. Switzerland. Excellent. Very nice. It's just so nice to see the broad range of experiences that you all bring here. Did anyone want to ask a question? I heard a bit about no. Maybe.
Someone raising his hand.
Yeah, that's okay. Maybe that's a raise hand because I've asked the question, Sarah. If you want to ask me something, just unmute and interrupt me. That's okay. So one important note that I wanted to say to you from the beginning, and I'm sure some other people have said it, is you don't have to have worked in pediatrics to be a good candidate, because there are lots of transferable skills that you can bring to the table. And we'll talk about them a bit more in a bit for this career motivation station. And I could hear Khalid talk about clinical governance and things like that, which apply to all of medicine. So all of those skills are definitely transferable skills, and communication and all these things will be useful and will be an asset for you when you come into pediatrics. So don't worry about not working in pediatrics if you haven't done it already. You are still a really good candidate. And I'm really excited to see, as I said earlier, how many people are in the room. So I should share my presentation, shouldn't I? So I'm gonna, I hope you can now see my second screen. Is that right?
Yes.
Yeah, let me bring the chat back again so I can see you all. If I can. Maybe I'm not able to do that. You tell me, Alham, if something comes in the chat. Is that right?
Yeah.
Yeah. Okay. So a little bit about my journey. I should share into pediatric training in the UK. So as we said at the beginning, I was born and raised in Romania. I went to medical school there and started working in pediatrics in Romania 2007. And then worked in Republic of Ireland for a couple of years and moved to the UK in 2013. So I've been here quite a few years now. I've just realized that we went above 10 years, which sounds like a lifetime. I applied to the Yorkshire Pediatric Training Pathway. This was later in 2013 in that round. And I entered at ST2 level because at that time there were rules, and I know they've reintroduced some of these rules for people who had a bit more experience, over 2 years, I think it was, and it is now in pediatrics, that you could not start in ST1. So you need to apply at a higher level, and now you have ST3 kind of applications. So I joined the training program in August 2014, and I joined the subspecialty training pathway for community pediatrics. So the GRID training pathway for community pediatrics in the last 3 years of my training. And I trained in West Yorkshire. So, and I'm obviously a consultant in Leeds where I've trained. And one take-home message is that most people who train in a place stay there because people are nice in pediatrics. So I have done a fair share through that. You can understand that I have done a fair share of interviews, and as I prepared for them, I think I went through this journey of understanding, why do I want that job? And when the reasons are clear to you and become clear to you, then you can make them clear to anyone else. You can add passion and enthusiasm to your answers because you know that is what you want to do, and regardless of the pathway you're going to take to do it, you're still going to do it. My main advice, and I'm probably going to repeat this at some point in the talk, is don't put unnecessary extra pressure on yourself for this interview, because you know, if you know you want to be a pediatrician, you will be a pediatrician one way or another. So yeah, that extra pressure that you might put on yourself is probably detrimental in the actual interview. You know, prepare as best you can, do your research, structure your answers, and we'll talk more about that. Have it clear in your mind why you're good. And I think that is something we as international medical graduates struggle a little bit to realize our strengths and our what we add to a place. But don't think like this will determine my career, this interview, it determines my life, so on. So don't go into that mindset. For some of you, granted, it might impact on visas and other practical stuff, but there are always other ways. So just tell yourself that. And tell yourself that we need you more than you need us, to be honest. Because it's true, workforce challenges are seen all over the NHS, and we definitely need you. You just need to be clear, and you need to be a bit structured, and you need to be a person that the panel wants to work with, to be honest. So one homework for you after today is to clarify this. Why do you want to be a pediatrician? And a few general tips, as I put on the slide. There are no perfect answers for this, because each of you have different skills, different experience, and different expertise that you bring to pediatrics, which is unique to you. And as you wrote your application, and I looked as at the beginning, I looked at some ST1, and I'm due to look at some ST3 applications later this week. For some people who wrote the application, it was very clear that they knew what they were bringing into the specialty and why they wanted it. Some people were not as clear. And as you wrote the application, I'm sure you probably realize how much you've done that is relevant to pediatrics as a career, and how many skills you've gained so far from all the work you've done in your medical career, but also outside of it. I'm sure some of you bring other things, voluntary work or other type of work, leadership work that you've done outside of medicine and outside of pediatrics. We all find it hard to talk about ourselves, of course, to highlight how good we are at things. I mean, there are exceptions, but most people find it hard. And one way I found to overcome it is to talk about your learning journey instead. Talk about how what you've done has changed you as a person, as a professional, how it has changed others, how it has changed the system around you. And it makes your answer much more rounded. It shows you're a person with insight, with a positive attitude to learning and improving all the time. And you're a person who wants to make a difference to children, families, to the profession. So don't, if you're really struggling to say, I did this and I did this, and probably you shouldn't just say that. You should probably talk about your reflection of the process and how that has made you a better person, and how that then has made the system around you and the people around you better, or has helped them in one way or the other. This station is your chance to show the panel why you're suited for a career in pediatrics, but also what do you bring, as I said, which will make our specialty even better. You've done voluntary work, great. That gave you lots of skills that are transferable to working in pediatrics. You've worked in pediatrics in 3 different healthcare systems, like I have. That gives you a wide, mature perspective on healthcare systems, on care being delivered to children and families in low and high income settings. It gives you really an appreciation for the NHS, which is a free at the point of access model that you want to contribute to. And those were some of my kind of reflections as I went through the career journey that I have gone through. Definitely give examples of when you structure your answers and you structure your reasoning for this. Give examples of evidence that supports this answer that you gave, and give examples of maybe cases or situations where you've contributed and this really helped. So here's some more examples of reasons why I love pediatrics. We have the best patients. That is not disputed by anyone in any colleague in medicine whatsoever. Our patients are fun, they're engaging, they're unpredictable, they're honest, they can get unwell very quickly, but the majority get well quickly too. I definitely remember a 4-year-old with an acute exacerbation of asthma that I saw in A&E resus. I gave them all the treatments to stabilize them as per the local guideline. We blew some bubbles in resus to relax them as well, because all of these things that we were doing to them were starting to get them a bit anxious. And then I remember continuing to review them throughout the night, adjusting kind of bronchodilators, worrying about them, and so on. And the next morning, I find them in the playroom, happy, smiling, still wheezing a little bit, but looking much better. And that is where I drew my job satisfaction from that shift. Kids are great. So think about maybe an example. When you say, I love working with children, or a variation of that type of answer, give an example of when you actually enjoy that and why, and how you kind of help the situation, what the child taught you, and that will make that part of your answer a bit richer. The other thing I like about pediatrics is that in pediatrics, you could go from looking after an extremely preterm baby on the neonatal unit to seeing a toddler running around, making his wheeze worse, like this patient I was telling you about on the assessment unit. Maybe then to an adolescent going through a mental health crisis, presenting to A&E, to then going to a child with complex physical and neurodevelopmental needs and a rare genetic syndrome like the ones I look after, to then the sweetest 5-year-old who can tell you everything about their health problem in clinic, which is another case that I had this boy who came to an outpatient rapid access clinic that I was running as registrar, and he told me all about his presentation with UTI some weeks before, which was just amazing. But no day is the same, and children surprise us all the time. They don't read the textbooks, which is a great thing too, because they come up and they come with challenging and interesting presentations all the time. The variety in a career in pediatrics might be the selling point for you. You could remain a generalist in pediatrics or become a specialist in one of the many subspecialties available in the UK. And I do really want to highlight that community pediatrics is the absolute best specialty. And if you want to know more about it, get in touch with me. If you're joining pediatrics because you have an interest in one of the subspecialties already, say you want to be a pediatric neurologist, then it shows you're focused, you have done your research on pathways to that career aim, and you're putting all the necessary effort and time to get there. You still need to be a good general pediatrician to be a good neurologist, and there are lots of generic skills which will help you on that career path. And if you mention something like that, and you mention you have this aspiration and you really understand that you need to be a good general pediatrician first, and then you will continue and hopefully pursue a career in pediatric neurology, then people will in the panel will be able to relate to you and kind of score you as high as they can, because we all like to see reflective clinicians with a plan and who are focused to achieve it. If you're interested in practical skills and have an experience in inserting cannulas, intubating newborns, have had some feedback from seniors that you've developed your skills to a point where you work independently or maybe even teaching others, or you're the go-to person when a difficult case comes, then you can say this and give an example. Giving an example of feedback you've received. So topping this up with feedback you've received, or with formal kind of multi-source feedback that if you've had that done already, that also would emphasize your point. You can definitely say that you would enjoy developing your skills a bit more in practical procedures. Say that you want to develop this for the benefit of your patient, because cannulation is stressful for children, for the majority of them, and their parents, and you want to make this as easy as possible to them. So when you give that part of the answer, you can then emphasize it by saying that you understand the challenges, but actually you are quite you're interested in developing the skill, but part of it is considering the environment and considering what help you have. For example, is there a play specialist to distract the child? Have we used local analgesia to help the child with the pain side of things, and so on? So you can start with saying that you enjoy or you have practiced a certain skill. Then you can talk about how you've grown your expertise in that, but also how much focused you are on making it a good experience with all the other factors kind of around it that I've mentioned. Again, it gives a richer answer from a more mature clinician. If you want to be a pediatrician because you have been inspired by some amazing pediatricians you've worked with that made an impression on you, then you can construct your answer around this. Say that you've been inspired by them, but also describe what was it that made them a good pediatrician. Kindness, communication skills, supportive to others, excellent clinical knowledge, anything that you thought and you reflected on that was really good, and then bring the answer back to you. So this is who I want to be in my future career, and I have the right skills and character attributes to be like my mentors, sort of, and a variation on that. The other thing that I really like about pediatrics is you're never alone. Working as part of a team, having good interpersonal skills is a required attribute. There is always someone to ask, someone to help you. And we work with people with a wealth of expertise in the wider team: nurses, speech therapists, physiotherapists, pediatric pharmacists, play specialists, advanced nurse practitioners more and more now, and other people who I might have missed. And us in community pediatrics definitely work with a lot of people in the wider MDT. And we're so fortunate to have such a team around us looking after children and families. And when we face more challenging situations, this is really when the team comes together even more, supporting each other, learning from experience, improving future practice. So if you're structuring part of your answer around team working, then you could give an example of how you've worked in a team and how that felt a good team working environment for you, and how, you know, if it wasn't in pediatrics, you could say, and you know that in pediatrics, team working is essential, and, you know, builds your answer around that. Don't shy away from saying that, you know, some aspects of our work are challenging, acutely unwell children, end-of-life care, difficult communication sometimes, upset parents. Generally, to be honest, all parents are upset because they're anxious, because they are worried about their child, because there was maybe a delay or a missed opportunity to treat their child. So really, they're upset for a reason. Majority of the 99% of parents. And I think if it ever comes up in the interview, I would really approach that type of question with empathy and with some compassion, trying to understand why the parents and exploring the reason why they're upset. What are their main kind of worries? Start addressing those, and then progress the relationship further and the communication further to what is happening, what you think is happening to the child, how you're going to help the situation. And again, 99% of parents will then really be on your side because they understand you're on their side and you're working together to look after the child. Aspects of child protection are also a bit challenging, or can be a bit challenging, especially in acute, because people are not coming to the hospital necessarily, obviously, with an understanding of child protection, and often it's something we discover, or A&E kind of picks up when a baby comes into A&E with a bruise, for example. So don't shy away from saying that some aspects of our work are challenging, but that is, to me, that is what keeps me interested and a bit stimulated to work through these things. And you can then say you are prepared and have the right skills to give patients and families the best possible experience, even if something very stressful, and even if something occasionally sad happens, because I'm not sure how many of you were involved in situations where a child was very severely unwell and maybe has not survived a resuscitation scenario. That is dealt with so much more sensitively and so much more in a very supportive way in pediatrics compared to maybe adult medicine. UK pediatrics is well ahead of other specialties in terms of team working and looking after each other and looking after trainees. Training less than full time, so flexible training is encouraged. You don't have to have a reason for it, and a lot of our trainees are now trained less than full time. And I have, in the last maybe 4 years of my training, I trained at 80%, which I thought was the best balance really for me. I'm also drawn into pediatrics and community pediatrics in particular because we have the unique opportunity to be a part of a child's journey throughout their childhood, and we can establish long-term relationships with children and families, help them achieve their potential, and we can make a positive long-term impact on a child's life. And some aspects of pediatrics are really linked with that. So, sorry, I've moved, haven't I? Yes. A few examples of types of questions that may come up in this station, apart from why pediatrics or a variation on that we've covered in the previous slide. But again, remember, this needs to be a personal answer, unique to you, and make the panel want to listen to you, want to hear more about you, and at the end of this, make them want to work with you. They could ask something around the lines of, tell us about yourself, or talk us through your CV. And a lot of people, myself included, find it really hard to summarize their CV and their career so far. I remember really struggling in my consultant interview just over a year ago to answer this question. It's hard, right? You've done so many things. How can you answer that in 2 minutes? But the panel doesn't want a list of your previous jobs. They want to see, as we were talking earlier, they want to see your journey, a summary of your experience that is relevant to a job in pediatrics or to the job you're applying for if you're taking this advice for other interviews in the future. Include in the summary clinical experience, managing common pediatric presentations independently, for example, seeking senior support appropriately, but also include quality improvement thinking, like something like you're continuously reflecting on your practice and that of your team, with a view to improve practice based on latest published evidence, for example. And you can include some example of an audit or something you were really proud of. But also, you can say you're keeping yourself up to date with evidence for practice. If you have experience of research, you can mention that. And this does include critical appraisal skills, not just completing a PhD. It does include some teaching skills. You can also mention maybe leadership, managerial skills, if you've had any sort of team leader kind of roles. You can mention voluntary work, which complements your other skills that I've just mentioned. And I would suggest, because this is a question that might come up, so I would suggest prepare a 2-3 minute answer for this that highlights about 3-4 areas to give this answer a good framework and a good structure. The risk is that you list all your jobs and waffle on without making your answer memorable to the panel, or maybe specific enough for them to score you well. So just structure it. It's something you can prepare ahead of time, and there will be a variation of this type of question being asked anyway. They might ask you, what are the characteristics of a good pediatrician and how do you fit those? Basically, they want to know your skills that fit pediatrics. You may want to talk about ability to apply holistic care to children, which really means that we see the entire child and we see them in the wider context of their family, their school, their community. And that is something we definitely do in community pediatrics, but in general pediatrics, we do that quite well. And there are other pediatrics subspecialties where that is applied. Now, the Royal College has an entire webpage on Choose Pediatrics, and I'm sure all of you have read that. And it has a lot of information on applications and things like that. I'm sure you've read it. But it gives you also inspiration for answers in this station. What are the characteristics of a good pediatrician? But choose the ones that fit you, because otherwise it will sound a bit artificial and learned as an answer. And I wouldn't want to hear that. They want to see who you are and what are your key skills and attributes. There are some really nice videos on this Royal College website in this Choose Pediatrics page, where a group of children of different ages ask a few pediatricians some funny but really also difficult questions. So they're only about 5 minutes each. So if you haven't seen them, they're really nice, and they can give you some inspiration on what you need to be a good pediatrician. They might ask you, what are you most proud of in your career or life? What is your biggest achievement? Which is, again, could be a question hard to answer, but this is a chance for you to show your potential to enhance the specialty. So if you've done something that helped your community, if you've done something that, a project that really impacted a group of people, if you've done some really good teaching that then changed how a group of people practiced that in that topic, anything like that. I mean, your biggest achievement could be that you've traveled across the world, but you need to structure that in a different way, isn't it? Don't only think clinical, professional, academic achievement. I would ask you to think, when you answer that question, think on wider impact on other people. As a first-generation migrant myself, I know we all have a tendency to think small, and some annoying voices like, what do I bring? Nothing. I'm really a simple person. These come to me all the time. And some days I feel like an imposter as well. Stop that voice, because it's wrong. The mere fact you've left your home country, traveled the world, adapted to a new culture, a new language. Some of you learned a new alphabet. You're coming to a new healthcare system. All of these are exceptional things, and just show how adaptable you are, your openness, your survival skills, your ability to thrive through difficult times. And the sooner you realize this, the better for you. And you'll be able to see yourself in a closer to the truth kind of light. Think bigger. Think anything that you have done which has made a difference to other people. They might ask, what is your biggest weakness? And think about something that you've learned from or are working on. They want to see not just the weakness, but want to see insight, how you thought about it, what have you done about it, or what is your plan to overcome this weakness, and how you put this into practice. I find it hard to say no, so sometimes I take too much on. I find it hard to stop, take breaks. I remember when I was doing acute, when the ward or the assessment unit was busy, I couldn't bring myself to stop, use the bathroom or drink some water or have some lunch. But I later realized that by taking breaks, my performance improved, and I had been reading even recently more published evidence supporting regular breaks for healthcare professionals doing shift work, for example. And by reading this latest published evidence, I realized that by taking breaks, I'm not only looking after myself, but in fact, I'm looking after my patients by making sure I perform at my best when I see them. So you can say, I really struggle to stop when there's lots of work to be done, especially when we're short-staffed and things. But then you construct your answer and you make it as in, I've reflected on this. I'm trying to understand the benefits of stopping and looking after myself as well during a shift. And so your answer is not emphasizing your weakness. It's just actually looking at how you've reflected on it and what are you doing then to overcome it, and why should you overcome it, really. So think about an answer maybe for this for this question. Now, a very good resource, as I was telling you, is the Choose Pediatrics page on the Royal College website. It has anything you need to know about pediatric training application. And I would emphasize to you, really read the scoring sheet for application. I mean, all of you have probably, or majority of you would have applied already, and you're waiting to hear about interview, and you're thinking about how to prepare for your interview. That's why you're here. But should you have to do it again, or if you haven't done it, very much read the scoring criteria for applications. And the interview scoring criteria is not published, but I suspect is very similar to that. So to the application criteria. And when you structure your answers, think, what would score me more points? What actually what are they asking with this? So as I said, I've shortlisted recently for ST1, and some applications really looked at this scoring sheet and included all the relevant information, plus reflections, plus impact. How did the QI impact something? how did you reflect through the process and things like that. I would just urge you to read that and structure your answers, even in the interview, very much in a similar way. This book really helped me. The medical interviews book helped me, I think, for the pediatric training application, and then it helped me again when I applied for GRID. I think it worked for me. It's not a big book, and it just some key sections. Don't think I read all of it, but some key sections are helpful to show you how to structure a good answer. So good luck. Relax as much as possible, because it will allow you to engage as much of your cortex as possible. When you're in fight or flight mode, it's your reptilian brain that is engaged, and your cortex is kind of in the background, just you know, trying to survive this. But actually, this is an opportunity for you to speak to some people who you might just think about them as maybe some of your supervisors or some of the people you admire in the field of medicine, and just think about it as a discussion, as an opportunity for you to tell them you're a good candidate and make them want to work with you. And just remember, there are multiple ways to your career aim, and don't add extra pressure. It really does not help in the interview. So I'm going to stop sharing. I think I've gone really fast, as I normally do. Let me make this a bit bigger. And there were some things. What does 80%? Okay, someone was asking about this, but I think it may have been answered, right? Yes, it can. It can increase your time in the specialty, depending on how much time you actually spend. And to be fair, there is no rush for people to finish. I think you can just enjoy the training program, because it's a very structured, nice, supportive environment. Yeah, I worked 80%, which meant for me, I worked 4 days a week. And that was the proportion of on-calls as well and stuff like that. Yeah, so really, you just need to show people that you're a good candidate and that they want to work with you. Any questions? Maybe yeah, if you have any questions, let me put my email address in the chat again. If you have any other kind of thoughts as you prepare for your interview and you want to email me, I'm very happy to help.
Thank you, Dr. Nigota, for the very rich presentation and stunning presence today. We are very delighted to have you today. Thank you for helping junior doctors and trainees in your department as well, and us helping us.
Yeah, come to Leeds community. It's a great place.
Rising.
All right. I'll just stick around for a few more minutes. I think you have a lunch break, is that right?
Oh, yes.
Yeah.
Moya, please, I have a question.
Oh yeah, of course.
Okay. I've been checking my Oreo and I keep seeing shortlisting in progress. I don't know.
So yes.
And shortlisting window closed on the 15th
Yes.
of this month. So what does that mean?
It means that all the people who are shortlisting, like me, have been given until the 15th to go through all the applications and score them. I suspect the college team will look then at all the applications and will be communicating with you probably in the next week or so, and to send people invites to the interview, I suspect. I don't know their time.
Okay.
Yeah.
Now, because what I'm saying is a long listing completed, shortlisting in progress.
Yes. So long listing really means that you've fulfilled the very initial criteria of qualifications and all the things that you put at the beginning of your oral application. That's the long listing part.
Okay.
Short listing is where you actually put So there are, I want to say 7 or 8 questions, the white box kind of questions that you have to fill out with your motivation and your leadership and your teaching experience and your academic experience. So that is the shortlisting part. I think it's the where you get a score out of 30, and then the college then will take those scores and then invite people to interviews.
Okay. All right. Thank you.
That's okay.
Yeah.
And can I just say other things I want to say to you before we go? I also teach, do some online teaching. So how to appear kind of engaged and how to deliver online teaching to people. Because these interviews are virtual, is that correct? Are on like a virtual platform. So I know it's not, you know, it doesn't determine your performance necessarily, but it does help test your equipment. So test your computer with the Wi-Fi you're going to use in the room where you're going to take the interview from, and make sure you have a backup, as in maybe a second device or a tablet or something that can you can take the interview on if the first one fails. But definitely test it. When the college sends you, they'll send you a link, and they'll have a few hours of where you could go into the platform and test it from the exact space where you're planning on taking the interview from. And then the other thing to think about is how do you look on the screen, okay? Because they'll want you to have your camera on. So think about your position in the room, what's behind you. Like I've done this painting here in the corner because I really did not like that corner being bare. So, you know, you don't have to do anything like that, but just think where you are. Does it look a little bit professional? Do you look a bit professional? Is there lighting that is coming onto your face? So like I have this lamp in front of my face. If I didn't have that, it's not too bad, but you don't want to be in the dark when you're in an interview. So think about those things as well. Maybe have a tiny lamp in front of you so it lights your face really and so then you can establish a bit of a rapport with a panel when you're in the interview. So think a bit about that scenario as well and how you're preparing for that part. Because yeah, I think sometimes people forget, and it just impacts on how people receive your answers and your message. It's not essential, but it just, yeah, think about that as well. Yes. Yes, because hopefully I am someone who people are happy to work with. Can you describe what the candidate you will be like? So really, I think you guys, if you're applying to be an ST1, what I would like to see is people who have maybe a little bit of experience, but that's not necessarily required. Really, what I want to see is people who are keen to learn, who are positive about kind of developing themselves, and who are constantly thinking about what could they do, or what sort of opportunities could they take to develop develop themselves professionally, and people who who have reasonable communication skills and who have a bit of a wider understanding, a bit of empathy, because again, children and families come to you sometimes at a very difficult time. So you have to approach that communication sensibly and, like a nice person. So really what I would like to see, just nice people who are interested in a career in pediatrics and who understand kind of what we do and how will they fit into the group of people that we are in pediatrics. I hope that answers your question. What is the meaning of interview window open and interview window close? I suspect interview window open means, I don't know really, whether it's, you can select your interview. I'm not sure if they'll give you an interview date, or you have an interview window you can select from. I don't know what that means. You can tell me a bit more, Ahmed, if you want. Is that on the timeline that was shared with you from the college, presumably? Is there any difference? No, there shouldn't be a difference in interview for every deanery. No, because it's a standardized interview process, and the questions and the scoring criteria should be similar, very similar, if not the same. What do you mean, Pariah? Does it affect your allocation? What do you mean? I mean, I know that some people apply to more than one deanery. I suspect that's what you mean. And if you are offered a place and you're successful in the interview to more than one deanery, I suspect you just choose the place that you want to go to and refuse the other ones. No. You're invited. You'll be asked to select a slot within this window. So yes, yeah, you'll just be given. They'll say interviews run for these 2 weeks, and that's when you select a date that suits you and a time, I think.
Okay, thank you, Dr. Monica, for the very rich presentation today. Thank you for having you, and thank you for highlighting the importance of reflecting yourself in a good person that panel would love to work with. And
I think, I think we've answered all the questions, isn't it? You can have your lunch now. I'll stop talking.
Oh no, I'd love to talk to you till the morning, but yeah, thank you. Okay.
Okay, get in touch with me if you want any more help or anything like that in the meantime. Okay, guys, good luck.
Thank you for your support. Thank you very much. So we're going to break. So like 30 minutes. Please come back by 12:10, everyone. Stay tuned. Thank you, Dr. Monica.
Hello, welcome back, everyone. So I hope you had a nice nice break and you are very fresh to come back again. Our next session will be a very important one about communication. And for some of us with no NHS experience, this is an extremely important part. So I'm very happy and pleased to present our speaker for the next session, who is Dr. Muttalib. He is a consultant pediatrics gastroenterologist and deputy clinical director for medicine and neonatology at Evelina London Children's Hospital. And he is the chair for pediatric gastroenterology operational delivery network for South Thames Pediatrics Network. He was trained in London and he has a special interest in gastrointestinal and motility disorders. He was the chair of motility working group of the British Society of Pediatrics, Gastroenterology, Hepatology, and Nutrition between 2016 and 2021. And he is currently a member of motility working group of both the British and European Societies of Pediatrics, Gastroenterology, Hepatology, and Nutrition. It's very thorough experience, and we are very excited to see what you're going to tell us about communication. The stage is all yours.
Thank you very much. Let me just try to share my screen. Who can share? Can you see my screen now?
Yes, we can.
All right. So thank you for asking me to talk. And it is always quite challenging just to speak about communication skills without having to follow on with a session with a practice. But let's just whiz through and see if we can come to something useful at the end of this. All right. So you need to decide communication skill is something that will follow you all the way through your career, irrespective of where you work. What you want to do is you want to share with the patients your point of view. You want to convince them, as a patient or the parents, by your viewpoint, and you want them to go with you through your journey to the destination you've already determined where you go. However, for the purpose of this session and for the purpose of the next few weeks, what you really want to do is you want to pass your interview. So you can see the two boxes are black and white. This is black and white for you now, meaning what you want is you want to develop skills that allow you to pass the stations of your exams. Whatever has happened or whatever is your previous experience prior to this, whatever you want to take from this session forward is the gray area, because the gray area is clinical practice that changes, that you modify, that you acquire, you develop different type of skills. But for the sake of the exams, you have one role. There is no real patients. There is no real clinical decisions. You are there to be assessed. The interviewer is there to pick up your point of view and to assess you and to see if you're suitable to take on, to be offered the position or not. So everyone come up with a very clear mindset, and the most easy you can make it for people to assess you, the most likely you will get the outcome you look for. So remember, there is no real patients. The role player are not really parents, and the assessor is not really your own consultant sitting next to you discussing real patients. They are there to give you a certain scenario for you to answer a certain set of questions, to assess certain communication styles, and everyone has a role to play, including yourself. And try to focus on the black and white of the condition for now. But stepping back and trying to figure out why is communication skills really important? This is, we all should be familiar with this now. So communication skills is major part of domain 3 of communication, partnership, and teamwork of the GMC Good Medical Practice. And it states very clearly, you must listen to patients, take account of their views, and respond honestly to their questions. And it also says you must give patients the information they want or need to know in a way they can understand. You should make sure that arrangements are made whenever possible to meet patients' language and communication skills. So whatever you're doing, as long as you're planning to stay working within the NHS, so at the boundaries, and those will be judged and assessed all your career, whatever interactions you have with patients through the good medical practice and communication have a major cornerstone in your day-to-day activities. But actually, most importantly, one of the major reasons for hospital complaints are communications. It's extremely unlikely. It's a very, very small number of complaints are secondary to a direct error. Majority of complaints are either lack of information. Patients say they felt uninformed about their care and treatment, or compassion. Patients felt they are not treated with compassion they deserve, or dignity, or they felt neglected, or the attitude was not what they expected, or they're not lack of basic supplies like extra blankets and pillows. So you notice that it's actually the majority of complaints are coming to hospitals are really focusing around how do we as individual or how we as an institution normally communicate with patients and with parents. And communication is not about you being right and being wrong. Right? So communication is also, you might both be right. Your patient might be right, you might be right, but you might just be looking at things from a different perspective. So the best way to move forward with any scenario of communication styles is not to insist your point of view. You might a lot of time have to step back, look into what actually the patient's point of view. You might not entirely understand it because your point of view is completely different, but their point of view could also be very different than your point of view, and that will give a very, very, very different outcome. And it is not only about, well, actually you stand in a different positions and you're looking at it from two different angles. You might all be looking exactly at the same thing, but you're seeing two different things. So it's not a matter about I'm trying to come to a communication scenario with a determined agenda to make sure parents and patients can see my point of view, because you can't. Here, you can see people are looking at exactly the same things, but they are seeing two different things. So that is where the power of communications come along, because it is not really a drawing and it's not really looking at things from two points of view. You are there to trying to convince patients and parents by a certain viewpoint. You're trying to communicate with them a scenario. So you want to see how can you get people to come to you to see your point of view. So effective communications has a cycle. It's an ever-evolving cycle. You have, number one, you have to start about what the patients or what the parents already knows. This is really important. There's no point of blabbing and juggling and moving and talking for 10, 15 minutes, and you realize this information is already known for them. So number one, really important, whatever you're doing in your real life, in the exam settings, in the interview, you will be given a scenario, or you will be given a bullet point to read beforehand that will establish what the patient already knows. In your real life, you need to establish this because that's really important. Then you assess what they want to know, because what you understand from what they already know and what they possibly want to know might be two different things. You need to ask them, or you need to establish what actually the value or what they want to get from the interaction with you. You have to be empathetic. You have to slow down. This is really important. Look, if English is not your first language, if you're not a native English speaker, a lot of us tend to compensate by speaking quickly. If you've got the pressure on, you've got adrenaline going on, you tend to kind of really speed up your language. And that is in a restaurant, if you're chatting with friends, that's all okay. But if you're really going into a difficult conversations, or if you want to establish facts for something, you need to make sure that you speak slowly and you kind of go and use your language very carefully. Keep it simple, avoid jargons, avoid abbreviations, speak very simply and tell the truth. Be hopeful, watch for cues, because every time you're not there to lecture people. Again, that you have to understand you're not in the communication. Oh, I know exactly what this is. I wanted to speak to them about non-blanching skin rash, and I just really lecture them about meningococcal sepsis. It's not about a lecture. It's about a communication in a backwards and forwards flow. And then be prepared for reactions. And we'll talk through those points throughout these presentations. Important things you need to be aware of is your position. So there are 5 factors you need to be acknowledged all the time. And if you've not acknowledged them so far in your practice, now is a time to look for and look into the details and dive into the deep end to see what actually they mean. Ritual and cliche, factual information, opinion, feeling, and report. What does that mean? So ritual and cliche, you need to be aware of how you start normally your conversation. For example, if you say, hello, how are you? The answer majority of time, 99.999% will be, I'm fine, thank you. But even if they're not fine, now you're stuck. Because then if you're not fine, they have to roll back for something you've already started. And if that is not your normal ritual, if you don't know how to get out clue from this, if you don't have a get out questions from this, you need to be aware that is what this question might land you in a cold water and you end up like, well, fine, how is fine, fine? And you know they're not fine. So the other thing will be about factual information. If you're setting a factual information, you should expect the factual information. For example, it is cold today. Well, yes, it is. I had to put on my gloves this morning. Well, I think the conversation finished now, right? Your opening statement become dull because then you don't really know what is coming from there. So again, it depends on your style. It depends on the question you ask. Expect to get certain things. Then opinion could be that a little bit much more tricky. Where you say, for example, that today, for example, this would be a great day to go out for a really good walk. Oh no, I think it's a day for sitting in and watching the TV. See, now you're completely started up in a different directions, and you're really starting the conversation in the wrong foot with each other. And that is would not often advise this, because then your conversation become already tricky, because the patient or family knows that you have a different opinion than your opinion. Feeling, I just feel suffocating with the daily travel and working indoors. Oh no, I'm happier when I'm more uncomfortable. Again, you're just trying to reflect your own viewpoint, but that's your own feeling about the scenario, which might not be shared with your patients. The report is what is the importance, the free flowing of exchange between two parties when they share with trust and respect, even with opposing viewpoint. And that's where you really wanted to start and where you wanted to come across. So be very careful about where you can And the starting point, I always tell people, I've been sitting on the other side in exams, in interview practice, in interviewing people from all the way junior, all the way to consultants. You really have to be your own self. You need to know your style. If any of you so far, they don't really know what's your own communication style, again, now it's a time to go, have a feedback, look into yourself, see what is your style. Are you a serious person? Are you a listener? Are you a talker? You can't wait, you're impatient? Or are you an internal optimism? Are you an internal pessimism? It depends what's your style. Because when the adrenaline kicks in, when you're stressed, when everything else is completely, you lose control, we all tend to default into our own personal style. And if you're not really sure what's your own personal style, you will become almost very superficial. And I see that all the time. I think people in the interview, people in the exams, they've been asking questions and then they default to a position and it becomes superficial, it becomes painful to watch. And that is what drags a mark out. So you need to start knowing what's actually your style. And then you also need to know what is the context, what actually is happening around you. And I'm trying not to really kind of, also, let me be funny. The common example I see all the time, it is, let's just talk when you do. I know you're not going for a clinical assessment in a way, but kind of all talks the child as you do the examination. And people are not used to this. Kind of they're trying to make up jokes in the middle in the way, and it does become very painful to watch. So please know the context. First example on your right-hand side, please don't pray for healing. It works. It works. Your insurance, if it works, your insurance wouldn't know who to reimburse, and it messes up your accounting system. Fantastic, really nice joke, but only if you work in America. It doesn't really have any meaning if you work here. There isn't really any insurance, there isn't really any reimbursement, and actually 50% of the British almost doesn't have identify with any religious values or in the religion in a way. So it kind of this is out of context. On the other hand, left-hand side, have a sore throat, penicillin. For some point, a lot of you might not remember that, but spot diagnosis was really something big, good few years ago. And you people will really looking forward to trying to say, oh, that is the best you can do. I can come now to a spot diagnosis. This is now a failure. You can't really have a spot diagnosis. So know the context of your joke, know the context of actually trying to be funny. If you find it too overwhelming, don't be funny. Just be factual. Starting point, practical tips. Always start by hello, my name is. We all wear this badge, and when you go to hospitals, we all do that in our own daily practice. Please don't underestimate the importance of actually sharing who your name is and what are you coming to the conversation with. This is painful to read, but that's actually in real life. This is I took that extract from a former review from a hospital and a former review from a kind of a poor communications. And you can see from patient's point of view, she say about a particular doctor, she explained about multiple organ failures, and she was dying and they would not resuscitate. And I thought, does that mean if she takes another heart attack, they wouldn't try to save her? I gathered it was because her organs were failing. They didn't see any point trying to resuscitate her. It wasn't a discussion, I'm just told. As far as I was concerned afterwards, it's quite brutal because of the way it came over. To be told, I wasn't asked. So the question of if there's any way, would you like us to? I was just told they wouldn't resuscitate her. So although patients could see the futility of resuscitations, the way it was told to them make them felt really quite disheartened by the discussion, and they felt really, really badly let down by this discussion. And how would that affect you? Well, actually, it will also affect us. As much as we're trying to see how we're very objective, I can go back and know what is the statistic is telling me if you're trying to consent someone for a lumbar puncture and say, oh, what is that statistic for doing that? What's the percentage? Yeah, I can go back and we're all told, and certainly me when I was in training, oh yeah, they get out, will say, I'll go back and collect the information and come back to you if you don't have them in hand. Well, actually, we're not even objective as a practitioner. This is a real life example and real life research. You have two groups. Group one, practicing doctors who were told that 90% of patients will survive 1 month after surgery. what is the choice you choose? And over 80% of the practitioners, or 80% of doctors actually chose surgical option. Another group, we were taught exactly the same information in a different way. They were taught 10% of patients will die within 1 month after surgery. That's the same meaning as what group 1 is taught, but slightly in a different way. And this group, less than 50% chose surgical option. So the way how you say things, no matter how much experience you are, no matter how much objective you are, will have a major impact on the outcome or the decision that you're making. So if that is happening for practitioner, or if that's happening for doctors, let alone what patients will do. So be mindful about how you're saying. It's not about just stating the facts. Both of them are stating the facts, but the way it's said can actually make a major impact on decisions that's being taken by doctors or by patients. And listen, listen, and listen. Look, this is the most major issue of complaint anywhere I've worked in. People don't listen. You're not listening to what you're hearing. It is just people hear and they don't listen. So please listen, listen, and listen. If you've not done that before, practice this. Listen, listen, and listen. Active listening is not just a passive listening. Ask open-ended questions. And we've established earlier, it depends on the type of question you ask, you might end up being completely shut down by the questions. Open-ended questions give people the chance to talk. People has hyped up to your appointment. People has been worked up to trying to come and tell you something. If you're asking them an open question, that's most likely you will be able to get them to give you the information you want them to give you. Request clarification. If they say something you don't understand, stop, clarify with them, then move forward. Be attentive, summarize. So when it goes, the blurb, the talk, 10 minutes, you stop, you summarize, say, let me summarize this. Let me make sure that we're all on the same page on that. Let me make sure that I understand what you're telling me. So all of these are really important. Summarize, paraphrase, reflect feelings, be attuned to their feeling. Ask probing questions. When the conversation dies down, you go into an area where you feel, well, maybe that is really quite difficult, I'm not really sure, then you might have to probe them a little bit. That's very different than asking a closed-end question. This is a probing to make them talk more about this. So now let us just focus about what are we all here for? Let us talk about, we're here for the interview. So what will happen in the interview? So I think, am I right that the interview is online interview, right? Yeah. So the issue with online interview is the communication scenario can feel very strange. The role play is on the other side of this computer screen rather than in front of you. This can lead to the whole scenario feeling very artificial and somehow can throw you off balance, particularly if you're not really done that all the time. So if you're going back to post-COVID where you don't really do clinic remotely, and you just do the word now, kind of having the online conversation is a little bit different. You need to have a certain etiquette for the online conversation and online discussion. But remember, the assessor are ultimately still looking for the same communication skill as if you were heading a real life or as if you're leading a real life consultation in person. So what they're expecting from you is exactly the same as what you would expect from you if they're sitting right in front of you. So you have to remember that in the back of your mind. Basic things. This is really important. Those are just all, I have to just put my hands up and I state my conflict in there. Those are all just random pictures I got from Google. I have no idea who those people, and I did not take any permission from any of those, but I suspect because they are available on a simple Google search, they are okay to say that to use. So picture one, look at here. It depends on where you put your computer screen. Okay, you almost feeling you're looking down. Yeah. Remember, the other people are looking the same as what you're looking at my position now, but the other people are also looking at the screen. The first one looked like actually you're looking down at them. Here, you're looking at your computer, and we're all guilty of this. Actually, you're not looking at your camera. It is what is projecting your picture is your camera rather than actually your screen. And if you're not reading from a presentation, if you're not reading from an article right in front of you, and you're talking to people and responding to questions, you look at the camera rather than actually look at your screen. And if you forget to do that, and if you don't remember doing that, I always advise people, put a sticky note right in front of the camera, say, look at me. then you always say, oh, there's something strange on my computer screen. There's a visual reminder and a physical reminder that you need to look at the camera rather than look at the screen. It makes a whole difference. You give the interviewer, you give the role player a sense that is you're looking at them in the eye. And although the last one, he said that you smile, you feel much more better, I really don't like this because the background is too bright. It's too kind of messy. It doesn't really give the impression that the whole setting is much more better. So if you look at the pictures up, here, no eye contact. That's exactly the position. Like, and if you're wandering around, you're trying to think, and you're looking everywhere, but you're not really looking directly at the camera. You give the people the impression you're distant, and you want to make sure that I actually warm. I look at you directly into the eyes. Keep looking at the camera. I like the background in the top pictures. The background in the top pictures, the background reflect well with the tone. The background reflect well. It's not too bright. It's not too dim, and it gives people a better position. So please prepare very well. If you're doing it if you do the interview on a laptop, make sure the laptop is higher. Then you look directly into it rather than look down. Make sure that you've got a decent background behind you. If you're trying to blur your background, make sure that you were setting contrast by which it doesn't really blur all the way. If you're putting a picture at the background, again, make sure be mindful about what you were and how much of that, because it's all an artificial intelligence type of way, trying to figure out your contour based on the pictures. So the best way today, put is something natural. Make sure that is you look at the camera, make sure that is you have a similar view rather than looking down and you're looking up, and that is make you a good starting point. So people will not really think like, it's okay. Because people in the interview, they will try to be as objective as possible. But when you are in the interview number 5 out of like 16, or interview number 12, you're tired. Okay. And that's natural, normal human things. So you become a bit more, just let me just go through the day, that is the last few interviews. So all the little small impressions make a difference, because then you put you in a different context for the interviewer, put you in a different context for a role player to try to help you get the best out of you. In the online interview, take focus history. It's not really a never-ending things. Remember all the time. I've never actually stopped reminding every person I mentor, every interview practice I attended with everyone, this is not a real life scenario. They're here for a reason. They're here to assess you. So the role player are not real parents. They're not a real child. In a way, yes, they are real human, but they are there for a role to play. So if you ask focus history, you will get the focused information that they will give you. You just need to get what the information they told. You need to get them that. Assess knowledge, because they are here for a reason. Clarify questions. If it become too difficult, if it become too confusing, stop and clarify and look for clues, because they will be something. They are there for a reason. They're not really just randomly patients who are coming, bringing their child to A&E at 3 o'clock in the morning, they're tired. No, they're here really for a particular reason. And just again, to re-emphasize, they are following a script. So if you think if you are suddenly the questions or the discussion is going off completely, then you must stop and realize, actually, I'm going off now, I'm veering off, because they can't stop you. They will just continue with you wherever you ask them, wherever the conversation going. But if you realize this is too random, you need to stop. And if you're stuck, which is normal, people expect that, stop, pause, take a couple of seconds to think. And I always find that is really, really a kind of a nice way to restart the conversation again. Repeat the last sentence that you were told. That will give the person that is in real life, in your communication skill, in your ward, in your clinic, in your interview, in your exams, wherever it is. If you're stuck, stop, tell them the last sentence or repeat the last sentence they've told you. That gives them the chance that you were listening to them, and that gives them the chance to pick up their train of thought from the last point, that is the whole sentence stopped. Okay? And then don't afraid to ask clarification. Ask people to clarify what they meant by certain things. Then summarize and make sure that's of mutual understanding. You remember picture 1 and picture 2? People are looking at from 2 different things. They might be telling you all the information you're telling them, but actually what you might hearing or might be seeing might be very, very different. Hence the power of summary. You summarize I am saying, let me remind you, let me stop here. Let me make sure that we both understand it. We're both looking at the number 6. Then you will be surprised. No, I'm not looking at the number 6. I'm looking at the number 9. Okay? So you summarize and you make sure that you both understood exactly what has been said, what has been discussed. Then give information and wrap up. Use simple language, use simple English, and wrap and summarize towards the end of your discussion. And most important things, please practice, practice, practice. If you've not done so, do it now. Find a partner where you practice with. If you don't have a partner, sit in front of a computer, record your practice, look at it again, and you will be very surprised how many times you can reflect on your own presentation when you look at it again. It's much more easier. Previously, we used to tell people, sit in front of a mirror and chat about yourself. Okay? And you will be amazed about how much actually there is a cue that is you constantly doing, how much people will use, and there is how much what we call the annoying habits, like it's just really irritating. If you keep doing that all the time, you might not be aware you're doing it, but it's just very irritating on the other side. If you have a habitual phrase you repeat all the time, again, if you've not had a chance to look and sit in front of a mirror or actually record your own presentations or record your own interview practice session, you might not be able to. People tend to add a lot of things in the middle of their sentences, and sometimes that could be a bit more irritating. You just need to be aware of it. You need to be aware about your style. You need to be aware about the cues you use. You need to be aware about your filler language that you use, because all of those do make a difference to the person sitting on the other side listening to you. Because why? Because this is not a real life scenario. They are there to assess you. They want to make sure A, listening is still good. B, communication style appropriate. C, they are not really blabbing things that is unnecessary. And they are able to reach the intended action from the stations. And I just literally finishing up with something. It depends really how much actually, if you grasp part of the conversation, what is a starting conversation could be today's topic is communication breakdown, and could very easily end up with, short and sweet, because you're not really listening. You're just trying to grasp things of coming across. And I have just one real life example really to say, and it is really important about, again, if you don't have a massive experience in the NHS, if English is not your native language, and apologies for people who actually speak English as a first language or the English as their native language, or if you're not used to the culture and tradition. So when we were in training, or we come in training, one of the communication skill scenario was to counsel a mother who got a child with trisomy 21, who got previously a trisomy 21 child. And one of the candidates said, good luck, or hard luck, sorry, next time to be better, which are good meaning things, are a kind of a translation from an Arabic way rather than actually an English one. And that was a fail, entirely fail. The role player stopped it straight away, and she said in the feedback they've got, this is entirely inappropriate, because you're not in the position to decide for them if it's a good luck or a hard luck or better next time, or hopefully next time it go better. You don't know them. It's not your position. Your position to stick to the fact and counsel them about the possibility. They can make their decision about a good luck or a hard luck. So minor things, so you can think, actually, that is how I say it in Arabic, or that's how it will work with me, or that's how actually I feel it should say it. It could end up being your failure in that station. So if you're not comfortable, if you're not really familiar, if you don't really have a wider exposure, stick to facts, practice, look at the screen, record yourself, listen to yourself again, listen to your video again, and improve the fillers, because you always, all of you by now, whoever been shortlisted, you have the clinical knowledge and the skills to do the job. It's really how do you actually interact with your fillers? That's all I wanted to say in my talk today. And we have, I think, probably a few minutes for questions, if anyone has a question.
Thank you so much. Yeah, there is a question in the chat. Let me ask, do I ask history in the communication?
Repeat again, sorry. What's the question?
Lemis asked, do
Yeah.
I history in the communication station?
So it is yes. If you're not sure, then you ask for clarifications. So it is not a history taking station, it's a communication station. But without understanding where you stand from, without understanding where the parents stand from, you might not be able to counsel them or conduct the communication skills. So if they are ambiguity, then you need to clarify those ambiguity. If those ambiguity will require clarification, will require a little bit of history, yeah, then yes. But remember, you don't take the whole 10, 15 minutes for taking history. You need to have a focus history, and that goes back to the point we said earlier. They will have the information being told already. So if your information you're being given, the blurb is not giving you the right information, and you need to ask, if you ask the right question, you will get the right answer. If you're not getting the right answer, you say, it means that you're on the wrong track. Stop, reassess again. Any other questions? So I can't see the chat, so I don't know if there's any.
No worries.
I can see the chat now, so it doesn't look like there's any questions, right? Look, questions about communication, let me push it a little bit further. Questions about communication, not really chat questions. So that's part of it. Questions about communication is really put your mic on, put your camera on, ask the questions. So you either got it completely, felt it is useless, or you've learned something, or you realize, well, actually, I'm perfectly good communicator for things. So it is now your chance, really within a smaller group, to put your camera on. Could you give us examples of common communication scenario? Why don't you put your camera on? We have 10 minutes left, right? How much we have? Yeah.
Lemis, would you please put your camera on?
Put your camera, put your question. Yeah, what's your question?
Lemis, if you can put your mic at least and ask your question. Lemis is not showing though, but her question.
Okay. That's all right. Her question was, can you give example of common communication scenario? You know, it can be anything really. It's not about the scenario. Remember, it's really not about the knowledge per se. You can be asked to say, can you go? You're the SD1, a child comes with acute hydrocephalus, the neurosurgeons are all stuck in theater, but they need to take the child on. Can you go and consent his parents? You've never seen a neuro shunt before. According to the GMC, as long as you're familiar with the procedure, you can consent for the procedure. You're going and talking to parents about this. The same as talking to them about lumbar puncture, which you've done hundreds of times. It is not about the procedure. Don't miss the point. The communication skill is not about, oh, I'm not familiar with this, or I'm very familiar with this. You're not lecturing them. Remember that what we talked about. You're not going to give them a lecture about lumbar puncture is a common procedure we do all the time. It has a very small risk of bleeding and has very small risk of pain. It has very small risk of coning, and we might get blood. It might be failure. It might not really get a lot of blood from this. It could be full of RBCs. We don't know. This is lecturing. This is useless. That's not communication. Okay, I'm here to do a lumbar puncture on your child. Do you know what lumbar puncture means? And if they say, no, we've never heard of it, then you need to clarify for them, oh, it is taking a fluid from the spinal fluid. Well, they realize actually those are school dropout families. They don't even know what fluid in spinal fluid is. You just need to stop again. Do you see? It is really not about, or you might be suddenly, could be actually speaking to a neurosurgeon who brought their child to hospital. If you say, oh, you know, the spine, there's such a bone in the back and where I do these things, you're actually speaking to a neurosurgeon who does all of this as for a living. So your communication needs to be very different. It's not about the procedure. It is about how you communicate to a neurosurgeon. You want to consent their child for a lumbar puncture to a people who is not actually going to school, a traveler family who doesn't really know if there's actually spinal fluid around the spinal cord. They know the spine, but they didn't realize there's spinal fluid. How do you communicate to both those extreme scenarios with a simple language, not to be intimidating and trying to make them understand that is you are taking a fluid from the CSF to send over to the lab for assessment, and how will that influence your management and what's the potential risk for their child. So it's really not about the example. If you're focusing what the example is, you're missing the point. It's about how you approach the position, how you will stop, clarify the position. Okay, I am not sure why you're doing the lumbar puncture. So do you understand why we're doing the lumbar puncture? Why my colleague has suggested to a lumbar puncture? That is taking a little bit of, yeah, oh, we do understand that. Do you want to explain to me what is your understanding why we're doing the lumbar puncture? You're still giving an open-ended questions. Then the answer will be, yeah, because we brought the child in, they think they might have meningitis, and they want to establish what is the cause for that. They've told you the information, then you've got the information, you need to move on. You're not carrying on, you're not really asking them, and do you know what meningitis is, and what's the symptom is, and what the sign is? No. You've got the information. You were being told, they understand what's the procedure for. You've taken your few minutes of history, and now you're going back again to explain to them what is happening, what's the next step, what is coming across. Does that make sense?
Yep, absolutely. So we have another question from Ahmed. How to break bad news? Yeah, again, that is really, really good question, because I think that's a tricky point for a lot of people. It's a similar principle. You have to remember, the same as the other things, this is not a real mother. This is not a real parent. You're not telling a real family that their child has a brain tumor. Okay? You're not telling them you've exhausted all the treatment for their AML and the child will go to palliative care. That's not their child. This is a scenario. They want to see how you, how do you look into breaking this news? So approach is the same. You do exactly the same. You introduce yourself, you clarify the setting, you understand, do you understand why you were sitting here today? Okay. Yes, we do understand why we're sitting here today. Do you want to tell me what you understand from Alfie? You understand from Ali? Understand from where we are with him? Yes, we do understand. Well, he had been vomiting for the last few weeks. We brought them to hospital, very lethargic. They did a CT scan, and I think that is now we're here to see the result of the CT scan. But you don't need to change the history from there. You know if we're coming across. So yes, we've done a CT scan, and the CT scan has shown a lesion in the brain that is causing compression on the brain, and on the certain part of the area of the brain that induces vomiting causes the pressure in the brain to go up. That's why the child is vomiting. Then you stop. See how this information is taken. Okay, completely crash, completely collapse. In real life, probably you will get a shock, you get collapse. In here, you will get a pretend shock. But you will be able then to tell them, or they will be able to direct you with a conversation, either crying. Obviously, in online one, they wouldn't, because you don't have a box of tissue, you don't have really kind of coming to cross them. So they wouldn't cry in front of you, but they would either be, oh, I wasn't expecting that. And then you need to stop saying, what were you expecting? Because it would not be, it has to be a script. He will not tell you something out of a script unless you're completely off. What were you expecting? Oh, I was just expecting might be infection. Well, I'm afraid it's not an infection. Let me repeat again. What we did in the CT scan, we realized there's a lesion in the brain that is causing compression, causing for this. You've established that they understand we're talking about lesion. Okay. And the next step, then what this lesion is. Well, from the information we have now, we think this is a malignant lesion that is a common tumor in the children. It's called meningioma or medulloblastoma, wherever it is, the common.
but we would need to do further tests to make sure that it is what it is. The other possibility, it could be this or that, okay? And then you stop again. The only difference between breaking bad news or having a difficult complication, it is you stop, gives them the chance to digest the information, moving on, gives them the chance on digesting information and moving across. Does that make sense?
Yep.
So in every step of the way, you stop, you summarize, you move to the next step.
All right, it's all clear now for that question. And then we have 7 minutes left, but we have one question from one of our colleagues in the academic office. I think he might have been through this in real life. He is a trainee. So he said, how do you explain the possible brain hernia complication in LP communication setting in real life?
So meaning that is, you need to clarify that a little bit. Do you mean that is a herniation has happened after LP, or you just want to tell them about it's not happened?
Thank you, I mean that the part of the communication, so it's not happened.
So, sorry, you repeat again, I missed what you said.
So I mean that is the possible communication that might happen during the procedure.
Oh, okay, okay. So again, it is really important to make sure that you're not really chasing yourself into doing this. So it is how much of a risk. So you're telling people about the common risks of the procedure. For a lumbar puncture, the risk of herniation is possible if there is a high intracranial pressure, for example. So you kind of need to explain to the family if you think that is a real, because the majority of lumbar puncture, that's not really a real risk, it's a theoretical risk rather than a real risk. You have a much more common risk that could potentially be higher in your list. You want them to understand first before you come to the real risks. That makes sense. This question is really important because you don't really go for lumbar puncture, start first discussing about herniation or coning secondary to lumbar puncture if the child is not presenting with high ICP. Okay. What's important for them, they need to be aware of that it might fail, it might cause a little bit of pain, it might cause hematoma, it might cause bleeding, and you might have to repeat it again. They need to understand this because this has a direct implication on them. Then you need to explain them there are very rare complications that could potentially happen, like the brain could take the fluid out from the spinal cord, the brain sit on the fluid, the lower part of the brain that just goes into the spinal cord, if the fluid being shifted very quickly out of the spinal cord, that part of the brain could push itself down to the spinal canal, and that could compress vital part of the brain, can lead to the child become very sick. But this is very rare complication. You need to make sure, you need to put it in the context. But because you're not really, if you're not scaring them off. If they say, I'm not doing a lumbar puncture, you're stuck. You have a genuine reason to want to do a lumbar puncture. So you're not scaring. Consent is not about scaring people. It's not about listing every single complication under the sun, ever man known. It's about the right context of what is important for their child, what is practical, why you're doing it, what's the potential risks, what is the alternatives. Okay, so if that did not happen to you in real life, I will be wary about starting my lumbar puncture communications or the whole discussion about brain herniation. I will leave that to the last bit and ensure that you said that's a rare complication of the lumbar puncture.
Okay, we have 4 minutes and 2 questions. The first one, is malignant a medical term?
Yes, all types of terms, medical, I'm not sure what you mean, but medical is it can be used, people will understand. Remember, whatever language you use, you will always stop. You can tell them you can tell them it's malignancy. If they don't understand it's cancer, you will always stop. It's not about what medical term, because it isn't really an English language of jargons. Sitting there, you need to make sure you double check your language behind, okay?
Okay, and the last question, can I draw in communication scenario to clarify for parents?
Yes, 100%. So that's what we do in real life all the time. So for example, in my practice, when I do endoscopy, I kind of just stand and draw them to the gastric, the tract, and say, this is a colon, this is what you're doing, but you're on the screen, right? So this is, wouldn't really be for things, and you can't really get the picture to show them. So yes, in real life, you will draw all the time because it might not make sense to the family what you're trying to tell them. but make sure that your drawing makes sense as well.
Yeah, all right. That's all for the questions we have. Thank you so much, Dr. Mutalib, for the great session. It was really...
Thank you very much, guys. I think I shared my email address with a wider group. Please do get in touch if you need anything, and good luck for everyone.
Thank you so much.
Thank you.
All right. So now let's move to our next session. So the next part of this day will be about reflective practice. I think it might be a bit new for some of us who hasn't practiced in the UK. So let me just introduce our next speaker, who is Dr. Habab Isa. She is pediatrics trainee. She is now ST7 in Oxford Deanery. She graduated from Faculty of Medicine, University of Khartoum in Sudan, and she has been working in the NHS for the last 3 years. So she is the founder, one of the founders of Soft Landing, and she's so passionate about celebrating diversity, tackling systemic racism and differential attainment and well-being of the workforce. And also she enjoys wide of range of stuff outside the work, such as photography, cooking, hiking, and international politics. And I just want to add one last line to the introduction, that Habab was the first one who did a mock interview with me before my first NHS job, and also did another mock interview with me as part of the BSAPCH mock interviews. So I owe her a lot for my soft landing to the NHS. Welcome, Habab, and go ahead.
Thank you so much, Aya. Hello, everyone, and very nice to see so many familiar names in the call. It's my pleasure to be here today. So, regarding the reflective practice, I was so happy when Muhammad asked me to talk specifically about reflective practice, because I have worked with so many colleagues in order to get their training numbers and their interviews. And I think as international medical graduates, most of us come to the UK with, we already got our MRCPCH, we already, the clinical exam, I mean. So we already got a clear pass with flying colors about our communication skills, or like communication station. And also we got our clear pass about our clinical reasoning and clinical thinking and how to manage emergencies somehow. But reflective practice is a very new concept to all of us. What I wanted to cover for my talk today is just to develop as a baseline a very good understanding for everyone about what is reflective practice about. Then we will speak about what is expected from all of you in the interviews, and then how to structure your answers and the common mistakes and pitfalls. In order to help me to place my talk today, I just prepared a very short, like interactive tool in order to touch base with your understanding about reflective practice and previous experience. If you can go to menti.com and use this code, we would be able to learn together today about what do you know about reflective practice. If you haven't used Menti before, just take your phone, go to menti.com, use this code 832355710, and then you will be able to interact with the questions. I will give you a few minutes to sort it out before we start. Menti.com. Okay, some people made it to the website. Yeah. So what after getting into the website, Habab? You use the code. Did you get the code 8235 5710? Sorry, Habab, can you say it again? I will put it on the chat. 823. Yeah. 55710. 55710. Yep, it's on now. Thank you. Okay. So the majority like are fairly new to the NHS, less than 6 months. Shall we move to the second question?
Yeah.
How confident do you feel about making a reflection on your portfolio? Either a verbal or written communication or reflection. Okay. 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 Thank you so much. So the majority are between not confident, somehow confident. Okay. Then let's go to the last slide, last question. From your experience, what do you think are the barriers to your understanding about reflective practice? Put any random words if you would like. The responses come like as anonymous, so I don't know who writes what. So feel free to share your thoughts. Okay. Okay. Yeah. Great. I think, yeah. Okay. Great. Okay, let's crack on with our session now. Thank you for your answers. Okay, so this one. So what is reflective practice? Just in a very simple terms, it's about a systematic way to examine and assess our thoughts. It's about being analytical about any experience that you come across in the medical, like as a medical professional, with the intention of gaining insight and using the lessons learned to maintain good practice or make improvement where possible. And I would advise you as one of the homework, like for the next week or so, to check the GMC guidance for reflective practitioners, and also to check there is a very good toolkit in the RCPCH website about the importance of reflective practice. And there is also a guidance from the Academy of Royal Colleges where they give you they run through several scenarios, and then they give you about like an overview about the tools used for reflection and how to write a reflection. So quite a powerful tool. And for me, like as international medical graduate, I was like, my consultant and supervisors were like, oh, you need to put more reflective entries on your portfolio. And I was like, yeah, why do I need to do that? I already am reflecting with my team. But as I progress in my training, I just realized how important the whole process is. Not only because like if you grow, like it grows, helps you to grow your understanding, your abilities, your leadership skills, your communication skills, but also even when you are like trying to like tag certain domains in the pediatric curriculum when you are a trainee, sometimes you don't necessarily come across a clinical case or you attend a certain course in order to cover that specific domain. So reflection is a very good way, like in order to put an entry, gather your thoughts. What do you think? What did you learn? For example, if you attended a teaching session about vaccination, for example, or like an RSV trial or something, you can go to your portfolio, write a reflection about that trial that you are participating in, or you were in a journal club, like attending a journal club, and then you gain an insight about how research trials can be conducted. You can go simply add an entry, tag certain domains about research, about like so many other like points that you can cover in the curriculum. So why is it important? So sometimes like someone can argue, why is it important? Like I can reflect on my own self before going to bed, as we all do every night. Why do you think it's important to reflect officially on with your team and in your portfolio? Anyone can just raise your hand, open your mic, and just tell me why. You don't need to raise your hand, just open your mic and tell me. Anyone? Aya, tell me why.
I think it's important to reflect on everything that happens for your own sake to do it better next time, and for the whole team to understand the individual stuff, and then we can have a wider structured policies, for example, of way of to conduct the stuff in a better way. So it's a room for improvement, basically.
So it's like a room for you as an individual to grow, but also an opportunity to your team to learn new stuff, and like to get an overview about things that we can do better, and to gain even an insight about what are we good, what like at our current practice, what are we doing well. So it's important because we need to recognize and continue our good practices. And this is usually like, it would be more powerful if we share it with our team members, then, or also to change and improve things that we are not doing well at the moment. Sometimes we take some practices for granted, and it's very useful in challenging practice as well. Also, it's important to monitor all aspects of practice on an ongoing basis, know when to find more information or support from others or from colleagues. This is an overview for the reflective practice that has been published on the GMC website and the Academy of Royal Colleges. As you can see, it's quite three main interactive sections, organizations at the level of organization, and then at the level of individual professional as a doctor, junior doctor, senior doctor, or even a consultant, and then leadership and education. So these are the three most important factors that usually in order to serve all these three sections, the reflective practice has been encouraged. And as you can see, at the end of the day, it's all about creating safer systems for our patients, safer culture, and a better patient care. When it comes to reflection, there are more than 6 models, I think, that I came across so far about how to write a reflection and how to even have the thought process of like doing reflections. I will tell you in a bit about which one is my favorite, and I will tell you why. Let's start with the Gibbs model, which I think has been published in late 80s. It was mainly about having this thought process, starting about what happened. Then this would be the first step where you start your reflection process. What happened? There's a first question. For example, I came across a difficult, there was a difficult resuscitation in the emergency department that I think I didn't handle well. What thoughts and feeling did you have? So it's about answering questions. And then you go about, oh, after that resuscitation, I thought I didn't do well. I'm not telling you that to tell the examiners that in the assessors that in your interview. I'm just trying to put it into a structure about like, how do we answer these questions in a personal capacity? I didn't do well. I felt a bit down. I felt a bit like not so confident in my management. And then we move to the next question. What was good and bad about the situation? For example, you can answer, despite the situation was a bit chaotic, the patient was safe at the end of the day. He wasn't harmed. And what was bad about that situation? For example, I didn't retain my clinical leadership on that scenario. So you can see, like, we start with one question, we answer that question, then we move to the second one. And with each single question you are answering, you are covering a different aspect of the whole scenario. Okay? And then what else could you have done? For example, in this scenario, I would say, maybe I should have worked more on my communication skills in order to make sure there is a closed loop communication during that resuscitation. Maybe I should have been more assertive with my team members. Maybe I should have, like, this is like the reflective process. So what would you do next time? This is the last question. Next time, from this experience, I will attend more simulation training in order to improve the leadership skills in a clinical setting. I will attend the relevant courses. I will speak to my supervisor in order to signpost me to resources from which I can benefit, and then I can be a better clinician for the next recess. Or I can take an initiative. It differs from one person to another. Or I can take an initiative to organize simulation session, training for all the junior colleagues in order to be in a better place to lead and participate effectively in resuscitation scenarios. Can you see how I went through a real life scenario, for example, what happened? Then I go about my thoughts and feelings. What was good and what was bad about this scenario? What else could have you done? And what would you do next time? Regarding this model, one of the disadvantages from my personal experience is I sometimes got stuck in what thoughts and feelings did you have, especially the feelings bit. So I like initially when I started in the NHS and I was doing my reflections in my portfolio, I was like, yeah, I don't necessarily like the feelings bit. I can process my own feelings in my own time, but in my portfolio, I want to write a kind of professional analysis rather than an emotional one. And as a female, I think it's very easy for us to get carried away with emotions when we start talking about it. So I tried another model, and this one is my favorite. It's like called Driscoll's model for reflection. It's basically 3 basic questions. What, in terms of what happened? So what? One of my colleagues was like, oh no, this model sounds a bit mean. I was like, no, it doesn't sound mean. It's about give yourself very basic questions and understand and just like try to work out the answers. And for me, this works best. Like I know like every person varies, how people vary in general, but just try to work through the model and see what works best for yourself. So what? Why was that incident important? For example, let's go back to the same scenario about a resuscitation that you felt you didn't do well. What happened? For example, I had a resus call. It was a child with severe bronchiolitis. I didn't feel that I led the clinical scenario as I wish as a senior trainee or a registrar. So what? Why was that important? It was important because it was like a child who was very unwell. I was a senior reg, for example, or a senior colleague in the shop floor, and I wanted to do better in order to make the child was safe, to make sure that the child is safe and he's improving. Now what? Here comes regarding what changes do you want to implicate in order to improve? So the buzzwords for the interviews usually is like reflecting with my supervisors, having an honest and open conversation with my peers, with my supervisor, in order to see how what did we do well as a team, and what can we do better. And then it's like the same cycle goes on and on again. There is another model for like that we can use for reflection using the 4 questions. And I had the chat with my other registrar colleague, and they were saying, oh, this is our favorite. We use these 4 questions in order to answer, like in order to put a proper reflection on our portfolio. What happened? What did you do? What have you learned? And what's next? My slide's frozen or something. Sorry, I will stop sharing and reshare again. My slides are not moving. Can you hear me, Aya?
Yes.
Okay.
Yeah. Number 10. Yeah.
So let's speak about the ST interview. As I said, from my experience, I think this part of the interview, people kind of give it the least amount of preparation, and I don't know why. We got all stuck and like consumed with the clinical scenario and with the communication, and we leave this bit just like we know there are a few acronyms that we can use in order to do reflection, and then we will stick to that acronym, and then we will give everything. But I think it's not about the acronym. For me, it's not about the acronym. It's about the content that you are planning to present to the panel. And once you got the right content in your hand, then it doesn't matter what acronym you're giving. Acronym is just about helping you to structure an answer. But if you don't have the right answer, then the structure wouldn't really matter, to be honest. Going to the ST interview, before talking about this station in the interview, I would advise every single candidate, please to go to the RCPCH website, go to the applicant guidance, and read once and twice and 3 times the content and the guidance for the interview. Please do not depend on your colleagues' experience. I know this is something we usually do, but this is not the right way of doing things. Please go to the official channels, write the guidance fully in and out. If you got any, if you feel there was any segments who are ambiguous, not really clear, come to your colleagues, clarify, and then share, you can ask about the experience of your colleagues and build on it. But the first point of contact should be the RCPCH website. This slide, I basically copy-pasted from the RCPCH website. What they said is this part of the interview will assess your understanding of reflection, okay? And how do you apply this understanding in your experience through your career progression? Then what they mentioned, they will ask you to reflect on a significant event from your career to date, where something has either gone well or not well, and reflect upon it to demonstrate how they will use their experience to help them grow or to help them through your career. They also mentioned, and I am stating, assessors will therefore start with the station by asking the following. Please, could you briefly describe a significant clinical event you were involved in or observed and discuss your learning from it? How do you use similar reflective practice in your daily work? They give you a hint. This station is designed to focus on an act of reflection and its subsequent application. Applicants should ensure they should spend the minimum time on describing the event and their involvement, and the majority of time should be spent exploring their reflection and how it has developed their practice. From my experience, as I practice with so many colleagues before, I'm mentoring them through the application, the major common shared pitfall is about people spending most of the time describing the incident and a very little time highlighting their learning from that incident and what did they do in order to make things better. So I want you to just start being in that mindset. It's not about the incident, it's about what did you do in order to improve, or what did you learn from that incident, and how did you apply that knowledge or that experience in your current clinical practice. My other very important note is please do not give any example that might implicate that you are not a safe doctor. And I'm also from various practices with so many junior colleagues. I have came across candidates who were so keen in sharing serious incidences, or like an incident that ended with the death of a patient, or like a near miss, and I wouldn't really be keen into sharing that in a national interview like panel. I'm copying that. I'm stating that from the RCPCH website. Serious concerns indicated on the score sheet on any station by either or both assessors. Serious concern will only be indicated if an applicant's response to a scenario highlights genuine patient safety concerns, property issues, or behaviors that could not be easily modified. And I have here then came across colleagues who failed their interview basically because they gave the wrong examples. They gave an examples that implicate they were not safe, and they gave an example when they implicate that like they didn't basically learn much from that. And I'm sorry to say that most of those candidates were like from outside the UK with no previous NHS experience. So my sincere advice would be, you need to prepare for this interview with like for a scenario that went well, a scenario that didn't go well, and please run those examples through a senior colleague or your supervisor. If you are not here in the UK, if you are not currently practicing in the NHS, please run your examples through someone who has been in the NHS for at least a year. Because not to undermine anyone's experience, but the systems are quite different. And what we have been like, our practice overseas is very, very different to what things are, like how things work in the NHS. So this would be my second important note. The first message, if you like, that you need to get out of this talk today is not about the incident, it's about what did you learn and how would you like imply that in your future, or how did you change your practice at the moment. The second one, please do not bring any conflicted example that might indicate patient safety issues unless you are cornered in the interview to speak about a serious incident. And I think one of the questions that came to the ST4 interviews last year in the reflective practice, it was about a resuscitation that didn't go well. And how did it change your practice? I think there's a bit of different aspect. And you need to be smart about the examples that you are giving. You can say something you observed, which can mean less implication on yourself as a clinician. But when you are mentioning an example that you were actively involved in, you need to mention something genuine, but didn't raise any concerns about safety. Regarding the acronyms, how to phrase our answer. Once you, as I said, my personal opinion, once you have the good content or the right content, it doesn't matter how to structure it, but some people love acronyms. However, do not just stick to the acronym without having the right content. You can use either STAR or SPICE. STAR, I do prefer STAR, but people do like think differently. It's about just a situation, what happened, what was expected, what was your action, and then reflection. You need to give most of the time to your reflection rather than describing the rest of the elements. Let's take one example. This is like some of the examples of the question that you might it might come to in your interview. Tell me about an incident you observed, you were involved in, and what did you learn from that experience? Tell me about a resuscitation scenario that went wrong, and how did that change your practice? Tell me about a clinical situation that particularly went well, and how did that change your practice? Or what did you learn from that one, and how did that change your practice? Just a bit of a practical approach to the reflective practice. Sorry, this is a bit of overcrowded slide, but this is an incident. A 4-year-old child with non-epilepsy presented to the emergency department with status epilepticus and was subsequently admitted to the pediatric intensive care. Sorry, just give me a minute. Admitted to the pediatric intensive care following a respiratory arrest. You were the reg on call that weekend, and you arrived to the A&E midway between the child's arrival in A&E and the respiratory arrest. I'm giving you the incident now, and then we will try to reflect on it together to write a proper reflection about the incident. The management of that child needed, throughout the management of this child, he received 5 doses of benzodiazepines. The child was then given a loading dose of intravenous phenytoin, which quickly stopped their seizure. The on-call consultant arrived as the child was being admitted to PICU. It wasn't until the child had arrested that the number of doses of benzodiazepines that the child had already received was clarified, to all the staff managing her care. These had been given by different staff in different places during the episode. At home from the family, in the ambulance from paramedics, in A&E from emergency department and nursing staff, and again by the attending pediatrician. So the likely cause of the respiratory arrest was the number of doses of benzodiazepines received. The child needed a short period of intubation in PICU, but fortunately made a full recovery. The immediate actions, the pediatric consultant was there. You discussed with her. You discussed with your colleague in the emergency department. You did a safety huddle or like a hot debrief. This was flagged as a near-miss incident through the hospital safety reporting system. And as part of your duty of candor, you supported by consultant, explained to the family what has happened and the errors and everything. And now you issued an apology, you did the incident reporting, so the governance bit is done. Now it's time for reflection. Is anyone particularly keen to try using any of the models that I mentioned so we can practice together how to reflect and summarize this incident?
I can try.
Yeah, okay. Who is that? Sorry, I can't see the names.
My name is Fatima.
Hi, Fatima. Yeah. Which model would you want to use? Shall I go back to the model or you have a structure in mind?
One model for 4, you told it's common. Your colleague like to use what happened?
Yes.
Yes, it's what happened.
Mm-hmm.
So what happens? The child has respiratory arrested.
Mm-hmm.
What did you do? We did like wrong dose of benzodiazepam. They give 5 doses.
Mm-hmm.
So and what did you do? Also, there is loss of communication. There is loose communication between the family and paramedics and pediatric registrar because they didn't take the accurate information. And also, they didn't follow the guidelines. So we'll give only 2 doses, and after that we'll give like phenytoin like that. But they give 5 doses.
Okay, good.
So what you have learned, I have learned if have any of these incidents of it is emergency and state epileptics, we should focus on the also we should not be distracted and focus of how many doses the child is taken. And should take like a brief history from the family and from ambulance staff. And also you should revise the guidelines before giving this dose.
Okay. And what's next?
Next we'll put I don't we make maybe a training session for staff and
Excellent.
also like one education session about seizure and how to manage seizure to all the staff.
Okay.
And also the kid family and ambulance staff and
excellent. These are the right answers. These are all the right answers. The first question, the first bit, what happened? I will just, because you mentioned the respiratory arrest, I will mention I had a child with a status of epilepticus who unfortunately had respiratory arrest. Full stop. What did you do or what went wrong? He received 5 doses of benzodiazepines due to miscommunication between the ambulance, ED team, and pediatric team. I recognize that when the child had respiratory arrest, that it might be due to benzodiazepines. I went back, I calculated, I found out that he received 5 doses. What have you learned? You mentioned excellent points. The importance of communication between the ambulance, ED, and pediatrics. The importance of retaining leadership because you are the registrar who went to a crash call. Yes, you arrived late, midway, there is a midway resuscitation, but as you arrive there, you need to have an overview about who is doing what, okay? And what are the roles? Are the roles assigned clearly? And then, as you mentioned, a very good point, this is not the guidelines, usually status epilepticus. We need to follow the APLS protocol about how to manage status epilepticus. Clearly, this guideline hasn't been followed. What's next? You can like, what's next? You can use the same points that you highlighted on what have you learned. For example, what's next? I went through our departmental guidelines. I made sure they are up to date. I delivered a teaching session to my junior colleague about the recent update on the APLS guidelines about status epilepticus. On that session, I invited the emergency department nurses and doctors to that session to make sure all the multidisciplinary team who deal with seizures are there. I sent a printout of brochures to the ambulance crew to keep them up to date, to keep them in the loop about what to do. I created a hospital passport to patients with seizures. So family can just like when they are managing seizures at home, they can clearly document how many doses of benzodiazepines they have given to their child. Is that clear?
Yeah.
Yeah?
It is clear, yeah.
Okay. So yeah. So if I use my favorite model, it was like a description of the event. In what it comes like a lot of what happened, what did I do, what did others do, what did I think or I feel, what I was trying to achieve, what were the results. And it's important when you are talking about any incident to give a statement about patient safety, where the patient's okay at the end of the day. So if someone asked me about, like as a personal opinion, I would prefer scenarios where a patient didn't get significantly harmed. For example, any prescription errors, like not a fatal or a major medication, not like something that can cause cardiac arrest or anything. So prepare something that, as I said, for the third and 100th times, that doesn't alarm any concerns about patient safety, please. And the other thing, prescription errors is always a good thing to talk about. Or if you are talking about a serious incident, I would be cautious about, say, like I would be more inclined to say, I have watched or I have observed this incident and learn from it, rather than I was leading that scenario that led to a major incident. Did you get my point? But I'm trying just to, I use this example specifically about the respiratory arrest, just to make you, like, as a practical example, to practice our models for reflection. Is that clear? Yeah?
Yes, it is.
Okay. So using my approach, so using my approach, like this was a child with epilepsy admitted through A&E and had respiratory arrest. It became apparent to me that the medicines received had been incorrectly dosed. In urgent situation, neither I or anybody else from the team had fully appreciated that. However, the child recovered well. I discussed what had happened with the family and with my colleagues in the A&E and the pediatric unit. This was flagged as a near-miss incident in our hospital safety reporting system. And one of the most important buzzing words is always about safety. Like I think Khalid might have covered that in the governance section about datexing or incident reporting. Give them a buzzword about like you are learning from reporting to the hospital safety reporting system, and then reflection, and then coming back. Always when you reflect, bring the personal bit. What did you learn? And what did you bring to the team? So what? Why was it important? Because I wanted like to check, even my knowledge was up to date, to consider what and others might have done differently. This was a near miss, so we needed a review to improve a care. It was hard talking to the parents about what causes respiratory arrest. It was very helpful for like a multi-professional staff to come across the protocols and the updates, and the importance of staying clear in acute situations. It also highlighted the importance of having closed loop communication system in resuscitation scenarios. So what will I do differently next time? So I already reviewed the literature, I updated our protocols, I emphasized on the correct doses, I emphasized on the pathways for medication check, and the importance of having a script who is documenting everything in a timeline. I have liaised with the nurses. I have reviewed our protocols. I spoke to the ambulance crew. So, like, our learning points are different, but it's always good to make sure that you included that you changed something in your department and to your colleagues from that incident. So I think we still have some time, but this would be my final slide, but I'm here to take any question. Reflection is an art. It takes practice to master. Please do not ignore your reflection practice station because you are like a bit worried about the clinical scenario and communication skills. Different models work for different people. Like, go through different models of reflection and find what works best for you. Make sure you choose a good example that doesn't raise any concerns about patient safety, and run your example through a senior colleague supervisor. Prepare examples for good practice and incidents. Practice makes perfect. You need to practice your reflection in a written and verbal form. So the first reflection I remember I logged into my portfolio was around, I can't remember, I lost, like, it was a very long one, and when I even like came across it recently, I was like, this was a very poor reflection, as it was as if I was writing a story about, it was like so lengthy, and even when I tried to look back at my learning point, they were not clear and they were not succinate. So yeah, practice makes perfect. So we need to practice how to reflect in a verbal and written way. Thank you, and I'm happy to take any questions.
Yeah, we have 2 questions on the chat. I just wanted to add that my very first reflection was so poor as well, to the extent my supervisor asked me for a meeting because of how bad my reflection was. So yeah, I remember it's so difficult to start with, but it can be mastered. So the first question from Aya, can please give example of how question will be? I think she means in the interview, how would they ask her? She said, if there will be any specific category to reflect on, what I mean is, will it come in general like good and bad scenarios, or they will ask specifically, like, for example, give me a scenario with ethical conflict to reflect on? I mean, to break down her question, she means, will the question ask her specifically about a specific incident in a specific area, like ethical concern or resuscitation or other stuff, or it will be just a general reflection question?
So in reflection, they can basically ask you about anything because they kind of know that, like, you can reflect on everything on your practice basically, but as the structure of the interview has like changed several times over the last few years, the questions that I came across and my colleagues came across were basically about, one of them last year was a resuscitation scenario that didn't go well, and what did you learn from it, and how did that impact your practice? Another one was a clinical case that was properly managed by your team. What were your learning points and how did it change your practice? I didn't specifically came across the ethical questions, unless Aya, because you had the interview recently, did you came across any ethical scenarios?
No, our reflection question in our interview, it was just a general, it was just, can you please reflect on any incident happened during your practice? And I choose to do a good one. So
okay.
Yeah.
That's good. Yeah.
So I hope that answers your question, Aya. If you have any query, just put on the chat. And there is another question from Ghaida. Can the scenario of near miss or respiratory arrest be used in interview? I'm actively involved as pediatric reg.
Hi Ghaida, nice to see you. So basically, personally, if I'm not cornered to bring a different, to bring like a difficult scenario or an EMS, I wouldn't mention it voluntarily. As I said, they have a very strong sensors about what can raise a patient safety concerns. It's not a bad scenario because this scenario is now, I found it basically in the RCPCH website on the guidance on the reflective practice, but I would use more non-inflammatory example if that's like politically correct to say. So prescription error is something that we prepared for in our clinical CH, MRCPCH clinical exam, and we know that what to do and how to do, and yeah, it's like a kind of benign example. Unless they ask you about a scenario, resuscitation scenario that didn't go well, like they asked this question last year, I wouldn't specifically talk about a near miss incident or an incident that ended up in a major harm or a severe harm or a death of a patient.
Okay. And there is another question from Sarah. How many reflective scenarios I was asked about?
You will be asked about one reflective scenario in throughout your interview practice. But reflective practice is very important, not only for the interview. I can see now even the application forms they are asking people to reflect on their experience. I was recently mentoring some colleagues who applied to ST1 and ST3, and I was surprised that even the application guidance has changed for the ST applications. The questions have changed in a way that they wanted you to show a reflective practice, to reflect on your clinical experience. And I think this has been a struggle for so many, because as international medical graduate, you got so much in your CV, but if you lack that touch of a reflective act or a reflective talk about how this practice, what did you gain from that setting, what did you gain from that job, you will lose marks and you wouldn't be offered an interview. I have came across so many very experienced colleagues who just didn't get an interview invite because they didn't go through the application guidance and they didn't answer the questions succinctly. So I would say it's not about the interview only. It's also about your job applications. It's also about your development as a trainee when you start your training post, hopefully soon.
We have 5 minutes on left. That was good timing. So I was just finished. Anyone has any further questions for Habab? Okay, everyone is thanking you. So I think there is no further questions.
Thank you, Aya. Thank you, Mohammed. Thank you, everyone. Nice to see you all today.
Thank you for being here. Okay. Okay. Marcel, yeah, there will be a recording for the whole session today. So, so we are okay to go to our next session. So it's gonna be the last one before the closure for today. And it's basically the light at the end of the tunnel, hopefully. So we're gonna listen to a successful story from recently succeeded candidates we have Rhoda Idris and Ilham Bikir. So Rhoda is now ST3 in Northern Ireland, and she is one of the heads and very actively members in the academic office, and she did a lot for today's session. And the other speaker is Ilham Bikir. She is again a member of the academic office, and Ilham has extensive pediatric experience back home in Sudan, and she was working in the West Midland in the UK as a pediatrics specialty doctor, and she joins the training, so she's currently ST3 in Scotland. So Rhoda, now the mic is yours.
Hello, everyone. Nice to meet you today, and thank you for giving us your precious time. So basically, my presentation will be just a reflection of what has been said. I think most of the things have been said by our lovely speakers today. So let me share the screen. Can you see it?
Yes, we can.
Okay. So my objective today is just to speak you through how to prepare yourself for the interview. What are the technical issues that you can face, and then the interview body itself. Okay, so the basic thing, it's always about to know yourself. If you want to prepare for the interview, you need to know yourself. Who are you? What's the best way that you can practice, and how can you practice? So for me, are you a visual person who likes to have, the monomimics, and you like to have the, the graphs and the flow charts? Or do you like to listen to, for example, audios like these lectures that we put, that you can, listen to them, our lectures, for example, listen to them while you're driving. So basically to maximize your effort for getting the most, The other thing, find your group. That was a so important step for me to prepare myself. I reached out to a lot of people, asked them, are you going for the interview? What level are you going to? Would you like to study in a group? So I had a group from different backgrounds and from different places here. Me in North Ireland, some people in UK, different places, and some girls in UAE, and of course, my dear friend Ilham in Sudan. So we connected together. So that's the other thing. Connect with your group. There's a lot of ways that you can connect. There's a lot of, social media that you can make use of. You have your Zooms, you have your Teams, you have your Meets and Skype. They're all good for you to practice, to make sessions, small session among yourself, to study, to share your materials, to share your photos, to share your audios. That was so, so useful for us as a group. And I always encourage people, make your groups as small as small as possible. Big groups don't work. You can have a big group, but you can have subgroups. I advise, 5, maximum 6. That will make it, I think, because there's a lot of discussion among the group itself. Is that the right way? Is that the wrong way? What should we do? What should we plan? So I always advise about small groups. And then planning. Plan ahead, plan ahead, plan ahead. Planning is very important. Okay, when are we going to meet, guys? That day, that time. Sometimes it's suitable for us, sometimes it's not suitable for other people, but we have to compromise, every time, find a suitable time for all of the group. Because of that, if it's a big group, it will not work. So a small group, probably they can compromise together. So planning ahead, what day, what time, how frequent we are going to meet, what topics are we going to discuss. So these are all important things. Planning is very important. And then the other things, what are your study materials? You need to know what are your resources, what should you get your information from. Don't forget, this is an online interview. There is, academic skills and there is practical skills you need to know about. So the resources is, of course, the Advanced Pediatric Life Support. pediatric guidelines, nice guidelines. Of course, you need your RCBCH, you know, to go through, as our lovely speaker Habab said, go through the, you know, how you will conduct your interview, the assessment criteria, what's the best way to do that. And for example, for applications, you always have to go back to your RCBCH website. And the other thing, a big star for medical interviews book. These are the two books. The blue one is the latest version of it. I will give a big star for this. This book is fantastic, guys. It's easy. You can get it from Amazon. It's not expensive. It's cheap. I think it's £20. And there's a PDF one for the older version, but it's more or less the same. There's no difference between them. But I really, really advise you guys to put your hand on this book. It's really nice, and even keep it for the rest of your career, because, for example, you need to go for a grid interview. Okay, that will be useful. You will need to go for your consultant interview, your job interview. So that is very useful book, and I hope everyone can get his hand on it. Okay, let's go for technical tips. This is very important. You need your knowledge, but you need your technical tips too, as our speaker said that. So what are your technical tips? Okay, first of all, you need to book your interview. You'll be sent a message and an email when you have been shortlisted to book your interview. Book your interview as early as possible. Choose a good time for yourself. Okay, this is a virtual interview system called Omicron Recruit System. You need to make sure that you have a good browser. Your browser is updated. You need to do it on a laptop or a PC. Mobile phone is restricted view, is not good. You need to check your headsets, your microphone, your camera, and your PDF readers. You need all of these working on your laptop or PC. You need to have definitely a good internet connection. Log in beforehand to allow for ID check. You need your passport and your driving license. That's on the day of your interview. And of course, no interruption, and make sure that you're sitting in a very quiet place, or your kid's out, your spouse is not there. So just make sure that it's a quiet place. Okay, so this is just the layout of how the Omicron system, sorry if I'm pronouncing it wrong, it looks like that. So you will have yourself and the host, and you will have a lot of things going in. So when they send you the email, they will send you a video. I didn't put it here. I don't want to waste your time for this, but they will send you a video. Have a look at this video, and they will show you how the system works. So you need to check, as I said, that everything is working. You need to dress for success. Make sure you are dressed well. That's a very important thing. Impression is very important. Move any clutter from the backward from the back in the camera. Okay. I think you are seeing now my husband's bicycle at the back, but it should be moved. Check that you have good lighting. And I think Monica said about that. Good lighting is very important, so people can see your facial expression, especially in communication. Make sure that you look at the camera. You don't look down, because I'm presenting at the moment, just looking at my presentation. But when you're doing an interview, you have to make sure that you're looking at the camera as if you are looking in the eyes of your interviewers. Okay? Act professionally. Smile. Don't laugh. Don't be grumpy. Try to be well looking. Okay? Cut any background noises. Make sure that you booked your interview in time where your kids at school, or they have been taken care of. Okay, always keep an eye on your timer. There will be a stop clock on every session. They will give you a 2 minutes beep before the end of the session. I will go through this right now. Okay. Okay, let's go to the interview body. How does the interview look like? And it's all have been set. I'm just putting it in one space and one time. It will be just how you will be assessed and what you need to do through the interview after you have, set yourself. So the first station, there will be 2 stations, 15 minutes. For myself, the first station was communication and reflective practice. So communication was 10 minutes and reflective practice was 5 minutes. So You will have 2 minutes to read your scenarios. Because of that, you have to have a good PDF reader on your computer. So you open it quick, you read it within 2 minutes, and 2 minutes before the end of the station. So what are you going to be assessed? You will be assessed according to introduction and general approach and attitude towards your communication story. You should show good listening skills, and you should show nonverbal communication, which is things that you do that shows that you're listening and that you're attentive and that you're empathetic and sympathetic with your patient. Because of that, you need the good lighting, so the interviewer can see your face. And then your verbal communication skills, okay, and the content at the end of the station. So for me, and I think for most of you, we like mnemonics. So for example, in my group, we used to do this at press. So it is introduce yourself, ice breaking. That means, be nice and very calm and quiet, sympathetic, empathetic. You have to explain what is your role. You have to ask who would like, especially if it's a bad situation or you're breaking bad news, you would like to ask who would you like to attend with you. Okay, you should explain your task very clearly. You should assess previous knowledge. You should recap every now and then and address the concerns of your patient. Be empathetic and sympathetic and understanding. And then finally, you summarize and you support in case of leaflet, websites, or referral. Okay, so that's just an example. That makes things easier for you. For reflective practice, I think Habab has did a great job explaining it. I have nothing to say after that, but it's a 5-minute station. You need to describe the event and your personal role in it. You need to reflect. You need to say clearly what are your learning points from that and the reflective practice. And you need to make a wider reflective practice. That means your CBDs and guidelines and flow charts and like that. So again, a simple mnemonic here. Start. It's situation. You speak about your situation. You speak about the task, the action that has been taken by you, and the result or the reflection. So this is a nice way to read. And you will find all of these, abbreviation in the book, in the interview book. It will help you with each situation, what kind of, framework in your brain you should work through them. And then the other station. So basically you will have one station which has 2 parts in it, and then you will be changed to another station, which is station 2. Again, you will have 15 minutes. You will have 15 minutes. You have the clinical thinking is 10 minutes. And again, the clinical thinking, one of the biggest things we need, because there is a lot of educational, and knowledge we need to go through. So basically what we did, me and my group, we went through the ABLS, for example, a child presenting with asthma. So ABCDE, that's our approach. What are we going to do for him? A child presenting with convulsion. We will either, put a story or use a story that has, someone had went through recently. For example, if Ilham had a child with asthma, so what did she do? What was that? So we assessed her clinical thinking, and then every one of us will say, okay, you did that right, and you did that wrong, and you needed to do that. So basically, it's taking every case in, the advanced pediatric life support, a child with asthma, a child with, noisy breathing, a child which is convulsing, a child who presented collapse, a child with injury. So it's all A, B, C, D, E, and F, as we have been told. And then this is your approach. And you will be assessed also about your escalation to your senior, to your consultant, transferring to a tertiary unit, including your transfer team and transfer letter. Escalation is a very important part of your clinical thinking. Again, your teamwork and leadership skill, delegating tasks clearly to other member of the team, your SHO and nurses. Even if you're saying, I will ask my nurse to put oxygen on the patient, that's delegation, that's leadership. I will ask my SHO to put a cannula okay, or I will ask my SHO to run the gas, or I will ask my SHO to go and call the consultant. So delegation to your team. I will call my consultant. I will call the tertiary unit for transfer. So these are very important parts of your assessment in clinical thinking. Communication, again, communication with your team in the local hospital. Do you need your ENT in your local hospital? Do you need your surgical team? Do you need your anesthesia team? So communication within your small team, as you have been asking your nurses and SHO and colleagues and other departments in the unit. So this is the way things go out. And don't forget, you need to communicate with the parents and update them about the current situation and further management plan. And then discuss ongoing management. Is the patient going to be inpatient? I'm going to, transfer the patient upstairs, or transfer into the pediatric ward, or transfer to, PIC, HDU. And, after you discharge the patient, sometimes it can go, if you have time and you spoke about follow-up, outpatient follow-up, GB follow-up, or a follow-up at the community level. And don't forget your development part. It's CBD, mini kicks, and procedures if you have done something. Okay, and then the final one was the leadership and governance. This is a bit of a very, it's not a very easy topic to speak about. It's a very wide topic. It covers a lot of things. So basic leadership, you can be asked about, a certain situation, a busy DGH, or a difficult colleague, or a difficult parent. So it's not really a very small, it's not like your clinical thinking where you have a child who's presenting acutely and you're going to do that and that. It's about how you manage and how you lead the situation in certain, situations. So it's the general approach and assessment, escalation, early if you need, again, teamwork and leadership, communication, ongoing management, and reflection. Again, you can use the same monomanic situation. You describe the situation, you speak about your task in it, and the action you have taken to make sure that everything is going smoothly and the patient is safe, and your team is updated, your consultant updated, and the result and reflection from the situation. Governance, again, is a very big topic, and you need to know what's your clinical governance. And I think Dr. Mohammed Abdul Muttalib has did Dr. Khalid has did a good job about speaking about clinical governance. You need to know about your teaching experience, your teaching style. Do you take feedback from your teaching? Did you do any coursing or your teaching? Because you might be asked speak about the teaching session you developed or you delivered, sorry. Again, audit, understand the audit cycle, your experience with audit. What are the pros and cons of audit? Research, again, and evidence-based medicine. So these are the things you need to know about. My question in my interview, it's just was a busy night and I have to lead through that. A baby's coming, a child, 5 patients sitting in ED is calling me. So it's how you manage things, who needs to be seen first, and how can you delegate things, and that's it. And for leadership and governance, if you feel that this is a thing that you're missing, you're not getting enough, I advise you with the interview skill book. It's really nice and it's really useful. Actually, we enjoyed ourselves while we're doing these scenarios, because we will say, okay, this is a difficult colleague or a drunken consultant, or there's a lot of funny situation in the book you can do, and you can act through them and learn from them and read, and actually it's really beneficial in your real life. Okay, practice. It's an annoying slide, but you need to practice a lot, as it has been said. Even, for my reflective practice, what I did, I had a situation, I went through a situation, I applied the STAR monomanic on it, and I recorded myself on a cell phone. And every time I listen to it, I figure out I missed something. And I go and record myself again. Oh, and I missed something, and I missed something, until I perfected it. And then you can, for your interview, what we did, us as a group, everyone has his own situation, and every time he will say the same situation, and reflect on it. You can have, for example, a good situation, a bad situation, and reflect each time on it, so you master it. But it's a skill that you need to do for yourself, for your work. So it's really good, and I encourage you just to do it, and record yourself on the phone. And then this is a nice guy. I like to listen to him. He has a very nice interview. He has a very nice video about interview. So for all my Arabic speaking colleagues, go and have a look at it. And for my other English speaking colleagues, he has subtitles and he speaks about the interview. And funny enough, he speaks about the STAR situation also. So this is, an international way to conduct interview. So basically, I'm sure all of you have the knowledge. We just will be missing a little bit of skills, technical skills, and how to present ourselves. And every time I tell people, just relax, don't push yourself too hard. You have the good knowledge. Whenever you feel like you want to rest, enjoy your time, enjoy whatever you are doing. That's the best thing to do. And thank you very much. And that's it.
Thank you. Thank you so much, Rhoda. So that was Rhoda's section. Thank you. If you have any question for Rhoda, because she is a recent successful one, you can ask any question you want to know about the interview. And now we're going to move to Ilham, Rhoda's friend, another successful one. She will tell us about her story. And then if you have any question for both of them, just let us know in the chat. Ilham, go ahead.
Hi, good afternoon. Nice to meet you again. My name is Ilham, one of the overseas applicant who applied from Sudan. Okay, so we always keep eye on Sudan. Can you hear me well?
Yes, it's clear.
Okay, and you see my slides, yeah?
And we can see the slides, yep.
Thank you. So there is 2 slides with many books. This one, if you can see this from my MD preparation, the orange one, and the other one from my MRCPCH, and in the middle is my daughter. She's taking my book, so obviously she's reading. So you have to work hard to gain it. I'm not going to say it's yeah, you will make it and it's an easy thing. No, it's not an easy thing. You have to exert an effort. So let's go through these slides. I had many considerations. I'm not going to repeat things because since morning we are doing the slides regarding the domains of the interview, and Rhoda covered part of it. And I practiced with Rhoda already, so I'm not going to do a thorough elaboration on this. So just to consider the requirements is very rigorous if you're applying from overseas. For me, governance was a bit challenging and reflections because we're not doing this every day there. And it's a very competitive. So if you see the last time, there is 340 people applied in 2023 and 55 being allocated to posts. So you have to show people that you deserve the position. You have to be a dedicated and passionate regarding pediatrics. It is a demanding field. It's not an easy field, and it's really demanding. So you have to be dedicated to gain all the domains being done in a good way. And there is a personal motivations that motivate. It's an engine, inside engine that drives you to the good place you plan already. So the mentorship, as I applied from overseas, is a bit different from people who applied from UK. I felt a bit like lagging behind, not knowing all the stuff. So who would be the mentor? What I'm going to do? So as Rhoda said, I approached many people who's going to do interview. Since application actually is a bit early, so I consulted the BSAPCH, and they do have like mentorship program. And there is a very helpful recorded videos on the media office and in the YouTube channels. So I consulted this as well. So you have to know with your mentor and which network you should consult.
Ilham, sorry, just for interruption. Can you put it in the slideshow mode so the slides will be in full size? So, thanks.
That's fine. Sorry, I should have done that earlier. Yeah, so pediatric training is a bit challenging and you have to weigh things. Are you going for this so you get well prepared? And there is another, from people who are coming from overseas, there is another part with financial constraints. You have to take this in consideration as well. And you have to balance the academic life versus personal life, since I'm being a mom for 3 children, full-time housewife as well. So taking care of them. So you have to make a balance, and your career motivation, how you do that. And it is a stress. So you have to acknowledge that. You have to know how to cope with it and how you de-stress yourself and what coping strategies you're going for. So you need to be emotionally and psychologically stable. It's like well-being, you know. So to survive this, you should acknowledge it's a difficult thing, so you know how to nail it, how to tackle it. So these are the resources. Again, nothing new. Already, you know this book. Rhoda gave you a picture of it, and these are CPCH. And this is the slides from oral. It's a screenshot from oral, like completion and acceptance of the offer. So my story is I've applied from overseas and I felt that like, I got discouraged. Many people said I'm not going to make it because requirements are different. And at that point, I didn't have my GMC application being approved. So I've just applied with like a reference number, but I have taken the challenge and I worked hard to get this done. So what I have done, I've a lot of extensive utilities of media and a lot of recorded videos and a lot of things to be done, right team, right people. And then Sudan war ensured, okay. And that was in April, interview was in April as well. So what to do? I sent them an email. In Khartoum North, which is an area of intense gunfire. I might not get well connected. I might have some technical issues, like we don't have electricity for 1 week. People don't have water. So it's a big mess. So how can I make it? So just make them know that I have struggles and I have obstacles, and they should know that I might get disconnected. So what are the alternatives? Are they going to offer me another day or something like that? So they were very understanding. And when I got disconnected, they gave me like international call from West Midlands. And yeah, so they allocated me to the right place. They got me help and supported throughout. And yeah, so Rhoda is one of my big fan, or I'm big fan of her. So we practiced together with one of Egyptian girls. Is very sweet. She's very helpful and very talented. And yeah, with Ahmed, he's one of our colleagues. So we did it all together. We practiced together before this. Sorry. So that was in the middle of Ramadan, where you're fasting and with all these difficult circumstances. So what I'm going to say here, it is difficult. It's not an easy thing, but you can do it if you exerted an effort and if you put a plan for everything, and if you got alternatives, and if you got a right team to help you through. So I've done an interview with a very high adrenaline. I've been very stressed because I was unsafe, my children unsafe. It was a complete chaos, absolute chaos. But I have no other way out. I started this, I have to finish it. I have to be strong. I have to be a tough lady. And I have to rely on my recall because I practiced well with my colleagues. So I prepared for all these things with my team. So we went through all scenarios. It's not all scenarios because there is sometimes change. So you don't know what's coming, but there is few difference. But I would say we went through all domains, all interview parts and all things. So I felt, yeah, that was saving me during this tough period. And I would here acknowledge the work of BSAPCH in helping IMGs and overseas people to survive their interviews. And I would say that Sudanese junior doctors as well have done a great effort in helping people from Sudan to relocate to the UK. So you never underestimate yourself, but you have to acknowledge that there is a limitations, there is something difficult, and you have to know your opportunities and your threats, strengths and weaknesses. So we call it SWOT analysis. I used to do this SWOT every single time I'm facing a challenge. And you have to work smart rather than hard. Being a mom, being a pediatrician is a bit difficult to manage. So I used to work rather smart rather than hard, you know. So utilize resources in a good way, do time management, because Rhoda based in the UK, Rayan based in the United Arab Emirates, I was in Sudan. So we have to manage the time to do the meetings, some of them doing on call, so we have to do this. Okay. You have to plan your journey, plan since oral application, what are you going to do, how you fulfill the white space, how you can tackle it. And I used to Google things, to use the search engine to see how people do that, and some of artificial intelligence as well, guys. Okay, and so you have to consult the right people, you have to practice. So I'm not going to say practice, because since morning we are saying practice, but really this would give you like, you will survive with practicing all. Okay, so for the interview day, you have to prepare the logistics. I'm not going to do this again because already been exhausted, but sleep well, guys, because I'm not the right person to tell you the interview optimal settings, because it wasn't for me. It wasn't optimal at all. But this, I had some sleep because I had to prepare some logistics with difficulties. Actually, my laptop was dying, so I sent it to one of our neighbors far away, an intense gunfire, just to be charged, to be ready to this. So you have to fight for your dreams. You have to know how you can get it with, yeah. So you have to do it in, I used to do it in a difficult way because this was my circumstances, but no regret. And I'm very blessed that I managed to have this with friend support, with organization support, with colleague supports. And I always used to mention Professor Muhammad Ahmed, because he always supported me all through my journey from pediatric registrar in Sudan and till now. He's supporting me. I'm not sure if there is anything yet to be done. So yeah, for interview day, you know, all this stuff being mentioned by all people before me. So you have to make it perfect, and you have to make it optimal setting, not like mine. And this is my email, just in case you want to ask about anything. So this is me fighting for Sudan and fighting for civilian government. And this is me being a mom. So you just like this, you have to twitch. Okay, so these are my 3 children. And this is me from Sudan, last clinic. I was doing clinics there. And this is me with NHS dress and bleeps. Thank you very much. I'm sure you will be fine. You will make it, but you have to exert an effort. You have to. Okay, so feel free to drop us an email if you have any questions. We're here to support you, not to help you, but because you already know the things, but you need some people to guide you, or to give a hand, because we already have people who gave us a hand to survive this interview. Thank you very much.
Thank you very much, Ilham. It was such an inspiring, touching, and ambitious story. You really did it with flying colors and difficulties, and we are all so proud of you. So well done. Good luck with the future. And that was the last session for today, and we will go to closure with Rhoda.
I just want to say one correction. As Habab said, you have to always look for the updates in the RCBCH website. They always change and update things. So the timing that I have spoke about in my presentation was that last year interview timing, but this year, so we have communication, which is 10 minutes, and then reflective practice, which will be 7 minutes, not 5 minutes, and then clinical thinking, which is 10 minutes, and governance, which will be 7 minutes. So you have extra 2 minutes for each communication. That was 5. So thank you very much for our wonderful speakers today. Thank you very much for our attendance. Thank you for giving us your time and believing us and trusting in us and giving us this precious time. And I would like to thank every member of the academic office for this day. We have some participants, some members who are not here today. I would like to thank Sarah, Ayat, Misa, Tagreed. I would like to thank the media office, Muhammad Osman, Isra, and Lubna. And thank you very much, our wonderful moderators, Aya and Ilham. Thank you, Muhammad. Thank you, Wafa. I hope you enjoyed this session. And please don't forget to give us your feedback. I'll put the code. And see you in a couple of weeks in a mock interview. Thank you very much. Bye-bye.